HERoS stands for Health Emergency Response in Interconnected Systems. Don't ask where the O comes from, because it's in interconnected systems. And it's a 3-year project of the European Union. My name is Gyöngyi Kovacs. I'm really happy to see you. I actually don't see you because I only see the light right now. But I've been super happy to lead this project, but I'm obviously not alone, and everybody in the project is here to tell you their parts, and I think that's the most important bit here. I had a few slides to tell you what the project was about, but since they are not the ones on right now, I'll just point you to some other things. Okay, I'm not supposed to move, apparently. So we had 4 main pillars in HERoS. One was about crisis governance, and a lot of the discussions and debates are going to be about that. And now my slides are on, right? Yes. There's and yep, here we go. Yoo-hoo. So the 4 pillars, as you see behind me, were crisis governance as number 1, local epidemiological spread, number 2. Then we had something about medical logistics and supply chains, and about misinformation and fact-checking. And you'll see the program today guiding you through these different teams. We have a lot of fantastic partners, and what is actually quite an interesting thing here is that we had a number of really great end users as partners who work with these issues on a daily basis, and who both helped us in informing, like, okay, what is relevant, what is important, what are we supposed to focus on right now, but also brought in their experience, the data, and we had this dialogue constantly. So I hope that you benefit from some of those results. As partners, let me just quickly point out who is who. So there's a HANKEN team with me here from Finland. Then there is the Nordic Healthcare Group here, also from Finland. As actually a company, in a way, it's a consultancy. Arctic has been putting together also this event, but a lot of the backbone of the project. CBK has been doing a lot of our data and visualization. The Italian Red Cross, you probably remember, as COVID-19 broke out, as a very first responder. They were very instrumental to scoping the project, but also to kind of really, like, even a case study came out of it, so you'll have to hear about that later. PCPM, if you've walked through here, you've seen a fantastic assortment of flyers and what all that they have been doing. You see that they have been as emergency medical teams out in the field, and obviously really kind of very active with pandemic response. Project Hope the same way, since they were already in Wuhan in the response active before even anybody in Europe had COVID on their radar. Then we have the squadron team. You'll see some drone simulations outside. Don't miss them in the breaks because they're really, really cool. And they've been setting up a stand for that. The Open University will be telling you about fact-checking, misinformation, to anything to Twitter bots. So really stay tuned for that. And TU Delft has been working with epidemiological spread and data and how to work with data in pandemics. And Vrije University in Amsterdam with crisis governance. So that gives you a bit of the picture of who's been doing what as well. Okay, for some reason this is going the other way. You'll see highlights, but I wanted to highlight a few things. We've been doing so many things, and today you'll see snippets of many of these, but maybe not everything. So let me just highlight some of the things that we are particularly proud of. You will see one of the documentaries this evening. We had also an arts exhibition in Amsterdam, where school children drew their feelings about the pandemic and how pandemic response and lockdowns have affected them. This on your right would be the ICU visualization tool that I think will be illustrated today a bit more in detail. One of the reasons that we are very proud of it is that this actually impacted on EU policy very, very quickly. Then other things to maybe highlight. We had the fantastic possibility to not just adhere to, like, okay, this is what we are going to do, but the EU was quite keen on us to engage in the ongoing issues. So when, for example, vaccines came about, we were even asked, like, okay, well, how do you do that with vaccine supply chains, with the ultra-cold chain, with different types of temperature bands? So we very quickly produced a fact sheet to help in those kinds of things. So that's unique for an EU project. This is why I'm highlighting it, because usually you write something, that's exactly what you have to do. Here we were not just allowed, but asked to actually come in and respond to the issues at hand. So this project itself has been responding to a lot of things. So that's why a little bit of a list of cool things. The other things you will hear more about later, but one thing I wanted to point out is that together we've also produced a massive open online course, so anybody who wants to learn more about also other aspects of what you're hearing today, or get more in depth with some of them, please just have a look at this course. It's always on, so you can anytime go through it and take the course itself. This is as much as it is here from now, and most likely, because of my voice, this is it, what you are hearing from me today. But really warm welcome and special thanks today to those of you who organized this getting together. So really special thanks to all of our Polish partners, to Squadron, to PCPM, to CBK. I know that you've worked super hard to get us here today. And to Arctic, without whom we would never have all the kind of like outrage, flyers, social media, all of that. So I hope you enjoy the day. That's it from me today. And this is today. So thank you.
One, two. That's indeed very, very bright. Right into my, thank you. It is for you. Okay, it works. Hello, everyone. Good morning. I hope that you get enough of a morning coffee and feeling great. Thanks, Gyöngyi, for introducing the project. My name is Mikhail, and we're like slightly getting into kind of like the work package by work package presentations. And this is the work package 2 that is on trying to understand how do we model COVID, how do we present COVID with data. So, and we have 4 people today here. So we're gonna have like a round of short presentations. I think my one is the longest one. And then we're gonna proceed to sort of like a panel discussion when we have 2 to 3 open questions from my side as a moderator. And then guys will be happy to also get the questions from the audience as well. Yeah, so this is the brief format. I think we're slightly out of time here. And we plan to finish within like 45 to 1 hour, right? I think this is the whole logistic that you have to know by now. Okay, so let's get started. So this is my talk. My name is Mikhail, and I'm a postdoc researcher at Delft University of Technology. To be honest, like the whole HERoS project is about to end, and I also would like to reflect a bit with you on how did pandemic went and how did we do like within the HERoS project. And the title of the talk is Modeling a Crisis During the Crisis. And as you can imagine, like, you know, when you're in a crisis situation, everything is like quite more difficult, right? So you're running out of time. And I think for the first work, for the first deliverable, we had 6 months to deliver a very large model, like with a lot of uncertainties, a pretty small team. You're sitting in your room and kind of like, how can I get there? So it's a difficult and challenging task. Whoop. Okay, some soundtrack. So if we'll get back to 2019, right, when it all started, so there was quite some uncertainty about what's happening, right? So, and while some like group of people, like some just believe that it's just going to be a regular virus, nothing going to happen. So other like a pretty, I think, minority thought that, okay, it's going to be serious. So we thought that it's sort of like a known known, so it's going to just die out, but apparently like it was known unknown. We didn't know how far it's going to go. Oh, that's weird. And when we kind of like figure out that it's not going great, so we started like, as a society, different countries started to experiment with different policies, what we can actually do to stop the spread. So, and, as the time progressed, so we did quite, like a number of measures in different countries, but it seems that the lockdown was kind of the thing, right? So many countries tried to do that. So we have Latin America countries, we have India who tried that. Australia did that sort of like relatively well, and then you can hear a lot of stories from Australian colleagues how hard it is, like, when they didn't see their families and stuff like that. So, and even in 2022, so China gave us quite some like a sense of how lockdown may look like as well, like, with all the social media information and how hard it was for like the citizens of China to actually go through that, all the measures. It was really, really difficult. So while we kind of like thought that, okay, lockdown will really help us out, it brought a lot of like societal and economic consequences, right? So people struggled a lot with being alone, with not being able to get access to education, to like their normal lifestyle, so to say, right? So we really wanted to have like our lives back, but on the other hand, we have to somehow stop the spread. And this is sort of like one of the final studies that we did within the HERoS project as a work package 2. We try to understand whether or not we have something that is as effective as a lockdown, but with less impact on the society and economy. So can we find something like that there? So what we try to do, like within the work package 2, we try to build models, right? And so here's like just in a couple of words to remind some of you, and maybe for some of you it's going to be a new thing. So this is the model intuition, and what we have here, we have 3 building blocks. We have citizens of a city that move around the city, living their normal lives, going to supermarkets, going to bars, going to conferences, and they visit different types of locations. So at those locations, they execute their activities. So if I want to go to the supermarket, I'm going to go shopping there. And so those locations have specific attributes that help us modeling the virus. They have like area, they have some number of people that can be there and stuff like that. So this is like a 3 main building blocks: citizens, locations, and activities. So why do we do that? We try to kind of like model that in such a way to be able to understand the impact of policies. So what's going to happen to a city if we're going to do nothing? Well, I think, well, there were like some countries who did that, but the Netherlands, and we did that study for the Netherlands didn't do that. They always try to do something. So, or we can also introduce a policy, a lockdown policy. And so what we're, and a part of that, I think a lot of complications were brought with the fact that virus was mutating all the time. So for example, we heard that, okay, alpha is quite dangerous, beta is not that dangerous, gamma is still dangerous, and that's kind of like, how do we go about that with all those uncertainties? And so what we want to observe like 3 types of impacts: impact on health, impact on the society, and impact on economy. And getting into specifics of the model, so this is the model intuition. So what exactly do we want to do there? So we want to simulate the model, and we want to explore the impact of like individual policies. So what's going to happen to a city if we're only closing down the workplaces? Or what's going to happen to a city if we're closing only schools? Right? And so we will try to keep that policy for a certain period of time. It's one thing to keep to close schools for 7 days, but it's absolutely different thing to keep schools for, say, 84 days. So we play with those individual policies, and we play with those with their combinations. Well, now it's getting tricky. So we see a lot of graphs, and it's still morning. I will try to explain that like step by step. So on those graphs, we have individual policies. Each of the graphs is for individual policy. So for example, like on the very top, you see what's going to happen to a city if we close down the workplaces. So the color there stands for how long the policy is in place. So the bright yellow, it's like the policy is in place for 84 days, and it started at the day 0 of the simulation model. And so the darker colors are the policies that are not that long and just started maybe later. So what we can immediately see from here. So we see that the earlier we react, the better. Well, that's not surprising by now, but apparently the simulation model is saying to us that it's actually really important to act earlier. So yes, and if we basically act too late, the spread is going to just overtake the whole city, right? So this is critical. We kind of searched here for tipping points that can help us to flatten the curve. I think we're all by now familiar with that concept. We have to flatten the curve or shift it. Another thing that is quite interesting over here, so what's going to happen if we'll start opening up too early? So for example, on the graph below there, we explore a single policy. We explore, I think it's masking over here. I don't really see. But if we remove that policy too early, it's going to create waves. So this is how we get there with waves. And actually, that's quite interesting, right? So it's kind of like at first we kind of think that we don't need waves because like we just want to stop that. But on the other hand, so when you create waves, you decrease an immediate impact on the healthcare system, right? So you kind of like you have a certain influx on patients at point 1, and then you kind of stop, right? You don't have anything, and then influx again. So this is kind of like a tricky choice to think about. So do we actually want that wave or not? So next, what we do, we try to understand how policies will work out together. We combine all those policies into some meaningful combinations. For example, at the very top, you have the hardest lockdown that you can imagine. So we do social distancing, we do social distancing, we do masks, and then we close all infrastructure. So really hard lockdown. And as you can see, even with the hard lockdown, if you keep it that for a little, so it's not going to work out. But then if you keep it forever, well, not forever, but for 84 days, it's still working. We also see that, well, yeah, this is exactly what I was talking about. We also see that, again, so even with combination of policies, if you will start removing too early, you will create waves. And again, so as we can see from those graphs, perhaps it's not really necessary to have the hardest lockdown to achieve those like healthcare impacts, right? So you can see that you have quite a number of yellow and low graphs with our combination of policies as well. This is, so far there was only about health. So the lesson learned from here is that it's important to act early, and it's also important to be aware of an early removal, what's going to happen. So now let's try to zoom in into the impacts, societal, economic, and healthcare impacts. And one of the tricky questions here is how we're going to assess that, right? So like we can imagine that having school closed for 1 day and having schools for like closed for 84 days is going to linearly impact, going to linearly increase. Or we can imagine that the impact is constant, right? So this is some of the questions that we have to resolve. And for now, we just assume that, okay, let's assume the impact is linear. So the more something is closed, the worse impact and increases linearly. So again, we have a set of graphs here. So we have here 3 types of impact. You see that on the x-axis. And again, the color here represents like how long a certain policy is in place. And so you can see like a number of lines here, right? So if we look at the first graph, so this is the graph for closure of workplaces. And so you can see that if we keep the closure of the workplaces, let's say for like 7 days, healthcare-wise, the impact is going to be massive, right? So we're going to have a lot of people infected. So this is the point here. But on the other hand, if we close down the workplace only for 7 days, the societal and economic impacts are low, right? But then you can see that, okay, if we're going to close the workplaces for 84 days, the healthcare impact is like minimum. And then you increase with societal and economic impact pretty much. So the interesting thing starts when we see that, you know, somewhere in the middle, the color is kind of like yellowish. There is a narrow window when, you know, the societal and economic impact and the healthcare impact are pretty much similar. They're not that high here. So, and this is again a sort of like a trade-off to analyze and to understand what we actually want as a society or like as a policymaker, what to prioritize here. Yeah, so sort of like to summarize, what we have learned from our simulation model is that we really have to act early. we have to be aware of the early removal, but also kind of like, maybe this is the open question for the panel, when we try to analyze and assess the impacts, so impacts to whom? And who said that this is, the impact, right? So I think the work package number 1 is going to talk quite a bit about, the impacts of COVID on different population groups, right? So again, like we can do those models, we can try to understand and predict the spread, but then I think the next step, and for future crises, is really to kind of understand how do we come up with those assessments, right? So like who said that this is the number, right? And if this is the number, like what can we do about that? How we can actually involve all these potential affected people into the process of building a model or trying to make them more inclusive and more comprehensive, so to say. Yes, and this is it. This is the great team. So yeah, I think all of us are smiling here, so it's pretty good. Yes, I think that's all for now from my side, and we're gonna go further with the next next speaker. Ira is gonna show you one of the dashboards that her colleagues built, and yeah, that's gonna be a showcase, right? Yep. Okay. Thank you.
Hi, I'm Ira Haavisto from Nordic Healthcare Group, and we've been working with Mikhail and his team on VP2, the work package 2 throughout HERoS. And actually, I'm going to show you the ICU map that we've created, but just a bit of background information first, what the whole work entailed that we were doing. We were actually interested, our team at Nordic Healthcare Group, we were interested in the healthcare system, and what Mikhail was talking about actually related to the system overload and the capacity. So when we say that we needed to flatten the curve, and that was due to how much the healthcare system could bear, we were interested in understanding more what that actually was. And the organization that I represent, Nordic Healthcare Group, it's, as Gyöngyi said, it's a consultancy organization, but we have a focus on research as well. And I actually have 200 colleagues who all work with healthcare systems and healthcare operations, and particularly with data analytics. So we have health economists, and we have service designers as well, who work and support healthcare policymakers and also clinicians and the healthcare operations, actually, all around the Nordics and also actually currently all around the world. So now I'm going to need a bit of help from our colleague up there. Could we look at the very short video first, and then I'll continue. So here's just a short introduction for the ICU map. Okay, then we're going to do as the video said. Let's check out the map. Do you think we could open the... Great. So what we were doing at Nordic Healthcare Group is we were trying to understand... our work was to try to understand the healthcare systems and how they were responding, particularly in this first 6 months of COVID-19. And our main question was actually to try to understand whether there was a difference between how different healthcare systems responded and whether also some systems were more resilient or had more capacity to respond to the crisis than others. And this was actually the main bulk of our work. But while we were doing this, we were analyzing data from all over the world related to healthcare capacity. And particularly the ICU beds became fairly critical at a fairly early stage of COVID-19. And we gathered manually all this data from European hospitals, particularly on their resources and their ICU bed capacity. And we were sitting on this data because we have collected it fairly early manually, and we thought this is very valuable, and it's taken quite a bit of time to collect it manually because it was very scattered. It could not be found anywhere centralized. And we wanted to share that knowledge that we had collected, and we created, therefore, this map or this interactive tool so that the information could be utilized by everybody. So it's an open tool, and as Gyöngyi said, it was actually utilized by policymakers as well. If we could move one page forward. Great, and if you could push on play. Thanks. So I'm just going to talk while it rolls. So we had the data that we had was from European hospitals. We had collected the data on their ICU capacity. So how many bed places, ICU beds they had. This was just a very small part of the data that we had collected, but it became quite crucial. And then we could also collect information about the utilization rates. This was being pushed out by locals, both countries and regions, on how much were they using or what was the need of ICU beds currently. And we combined this information and made an interactive map or geographical map. So up there you can see when the dates are changing. These are the real dates and the real situation in Europe at that time. So what we can see is where we have a blue sort of round circle. This is where we that's the utilization. And then when you can see the more darker spots, that's how much capacity there is left. And soon when we move a bit forward with the dates, there's going to also be some red dots. Let's see if we get there. And this is when the capacity was actually overloaded, what Mikhail was talking about. And then you might ask the question, so what happened then? Well, most of the hospitals, right, they managed to have temporary beds or to reallocate resources locally. And what our research findings actually said was that during the whole first 6 months of Corona, of COVID-19, even though there was an overload in certain regions in Europe or in certain hospitals, actually there was always capacity somewhere left, right? And this information was, of course, it was not available at the time where policymakers or hospital directors needed to make decisions. It always came a bit with a lag, this information, and because for one hospital director to start looking for what's the capacity in your neighboring country's hospital in a time of crisis is not very easy. So that's what this map is actually doing. And now you can see in certain countries we had a capacity overflow. So if you think this is interesting, this is an open page. An open tool, so you can go and play around with it. And also there's some additional analysis when you move forward with the pages. I don't know if you can see from there, but this is page 2 and it's up to page 5. And you can also choose different dates for if there's a specific time period that you're specifically interested in. Yeah, and for some countries where the data was available, there's also a regional analysis. For example, for Italy, you can see how the capacity and the utilization changed on a regional level. So, yeah, I think that's it for me. I wanted to share this interactive tool with you. And thank you.
I think we now proceed to our next speaker. I think it's Anna yet, right? Anna goes first, and then you're gonna, yeah, Anna, yeah, yeah. That's the lineup.
Good morning. My name is Anna, and my presentation will be the shortest one. I will speak about the visualizations. The real data, the availability of real data and models change is a game changer for responding to global threats such as pandemic. But let's look at this data. Well, I cannot see any pattern here. The lines between data are not cannot be seen just because the data are too complex. Even if they are presented in a tabular form. So that's why we need visualizations just to translate the data to actionable data insights and to help the decision makers to introduce adequate policies. But the visualizations, they must be tailored to the user's needs, to the target audience first, and second to the purpose. And in our case, the target audience, in the case of COVID-19 visualizations, were the policymakers, the healthcare professionals, and the public audience. And the purpose was, of course, to increase the situational awareness, especially regarding the number of infected people. So the work on visualizations should start from defining the target audience and the purpose. Okay, this way. And soon after the outbreak of pandemic, a number of dashboards appeared on the internet. The first one was was developed by Johns Hopkins University from the USA. The second, which is well known, is the dashboard of the World Health Organization. I'm sure you are familiar with at least some of them, as we at that time we were all looking for information on spread of pandemic. And within HERoS, the Space Research Center developed two interactive dashboards.
Anna, can you please use the mic?
First one was
talk into the mic, please. Yeah.
The first one was related to the population of The Hague, so 500,000 people, and we use the ArcGIS online as a tool to prepare these visualizations. So you can see here the outcome of 3 policies, which were simulated, modeled by the Technical University of Delft. So the team of Mikhail. And here we have three policies: the policy no lockdown, the policy of soft lockdown, and hard lockdown. So we can compare the outcome of these 3 policies and look at number of people infected, hospitalized, and those who need the admission to the ICU, deaths and recoveries. We can see this on line graphs and logarithmic graphs, and also on maps. So the spatial distribution is shown as well. And we can see and compare the outcomes of different policies in 7 days time step, and in 2 divisions of the city, neighborhoods and quartier. And also, we can compare the outcome of policies activated on the 1st, 7th, and 15th day. So the time of introduction of the policy is very, very important. Sorry. Okay, the second application was related to the bigger population of The Hague and The Hague conurbation. And different policies allowing travel from a satellite city which was highly infectious, and policy allowing travel from a neighboring country. And we have taken into account 4 scenarios. So here you can also choose the state of agents, like susceptible, infected, exposed, infected, asymptomatic, symptomatic, hospitalized, on ECU, dead and recovered, and compare the chosen policies and scenarios. And the same using maps, so the spatial distribution is shown, and we can see here the neighborhoods, the distribution in neighborhoods, in The Hague conurbation and in quartier. So, thank you.
Yeah, our next speaker is Rafał Bartczuk, and he's representing Interdisciplinary Center for Mathematical Computational Modeling, University of Warsaw.
Hi, my name is Rafał. Thank you for inviting me here and for the opportunity sharing of our experiences from ICM Epidemiological Model team. I'm here to tell you the story of our epidemiological model. I'm the social psychologist, by the way, and my role in the group was analyzing behavioral data, but it's not about this. Okay, so the story started in 2008 when the full population agent-based model for simulating influenza spread was developed in ICM. But this model was abandoned because there was no interest from the politics part and from the science funding agencies also. The team was dispersed. In February 2020, we quickly revived the model and began actively working on adapting it to the specific biology of the SARS-CoV-2 virus and to crisis governance unfolding because of the COVID-19 epidemics. At that time, we were relatively unknown and even perceived by some people as some eccentric people talking about the possibility of predicting epidemics. But we reached out the institutions such as the Ministry of Health, Polish Sanitary Inspection, Institute of Public Health, and Governmental Bureau of Security with our preliminary results. And some officials and decision makers responded positively and recognized the potential and benefits of mathematical modeling in understanding epidemics. And we started to be official advisors to these institutions and a part of Ministry of Health team for modeling, for monitoring and forecasting the spread of COVID-19 epidemics in Poland. But it was not solo journey, of course, and in this journey were involved various stakeholders, and especially we have collaborated with the MOKOS team from the Technical University of Wrocław. It was the second modeling team advising the Ministry of Health during the epidemics. And our work also gained substantial media exposure. The model gained recognition and became a household name in the media. Okay, main idea of our approach was to provide detailed representation of the socio-demographic structure of Poland, coupled with the probability of virus transmission, and the model has 3 layers: social contact structural layer, epidemiological layer, and control and reporting layer, which allows us to adjust the parameters of the model and to report the results of the model. Okay, a few words about the virtual society. Our model is full population model simulating over 38 million virtual inhabitants. Here we see, I don't know if there is, okay. Here we see our colleague, in fact, the main engineer of software. Gdańsk is somewhere here. The point view is from Warsaw. And these agents are meeting in something we call context. These are places like households, educational units, and workplaces. And also the contact between agents can occur in common public places, and also the long distance travels are implemented in our model. The illustration of the structure. The virtual society is highly detailed, exceeding the typical requirements of epidemic spread simulator. For example, you can see the composition of the household. In our model, of course, the composition of our household of people living here, and we can see that there are 16 people living in this household, and they even have names and surnames. Of course, it's a joke because they are artificial, but it is showing the level of realism of the representation of the virtual society. Okay, and the second layer is the epidemic layer, epidemic dynamic layer. We have implemented variant-dependent infection probabilities, elaborated disease-related states, vaccination, incorporation of vaccination data into the model, cross-immunity between variants and vaccines are accounted for also, and the model includes immunity waning process in 2x scales. And what is important, also the model incorporates risk exposure changes, like changing in contact rates in different contexts, natural, seasonal, or dependent on NPIs, on governmental policy, self-isolation, quarantine, and also partial school closures are implemented. I will skip some, because I was prepared for a longer talk. I will skip some technical details. Okay. One word, during during the epidemics, we worked on the old software, but we also produced the new simulator, which is complementary to the old one, and we are in the process of opening the software into the of opening the software. So just to know. Okay, and some insights from our reports. It's not systematical because it's a lot to show, but just few important points, important features of the result of the report. First one is that we can show the states, the disease-related states of agents on the map. So here we can see, in the left up corner, we can see the susceptible compartment. Here are infectious asymptomatic, infectious symptomatic, and hospitalized. So this kind of visualization can, thanks to this kind of visualization, we can visualize, for example, the regional effects of policies or the regional needs, for example, for ICU beds. The second feature is the scenarios analysis, and I won't talk much about this because others talked about scenarios. But here we have the main results of the model, the main outputs of the model: new cases, deaths, COVID-related deaths, hospital beds, and ICU beds. I just show one interesting thing, that these two scenarios differentiate in immunization of the society. In the pessimistic scenario, 32% of society was assumed that it is immunized. And in the optimistic scenario, 55. It's only 10 percentage points difference. But the difference in result of the model are huge, let's say. It's 2 times in the number of deaths in the peak of the wave. So such kind of analysis is very important, not only in showing which kind of policy is better or worse, but also what what is going on during the epidemics and what are the consequences of these processes. Okay. 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 And the last part, I would like to show some experiences with the how our model was used by decision makers. On the left side is the visualization based on our model outputs. These red points are the concentration of new cases, and on the right side we can see the timeline of the epidemics and the timeline in terms of new cases also. So, on the very beginning, very beginning of the epidemics in Poland, our first analysis delivered to the Governmental Bureau of Security made a case for maintaining restrictions during the first wave. We can see here the first wave. In fact, we can't see here because it was very small wave compared to other. And these are this first, in fact, the preliminary results of our modeling, but they were used as an argument for maintaining restrictions during the first wave. Okay. Now we have the second wave, and Norbert Maliszewski, who is the State Secretary in Chancellery of Prime Minister, justifying lockdown, referring to the ICM epidemiological model. Okay, so we can see this outbreak. During the outbreak, okay, during the second wave. And also during the third wave, also decision makers stated that the outbreak of the third wave was in line with our predictions. And we also predicted the fourth wave, the Delta wave, which was the first wave which reached herd immunity level and turned down without restrictions. And we predicted this, but of course we didn't predict the Omicron wave because we didn't know about the strain in this moment. Okay, so here we have the Delta wave and the Omicron wave. Yep. Okay. The model has given a comprehensive picture of the epidemics, enabling us to understand the spread, peak, and decline of the pandemic's successive waves. And one more visualization. Now we have new cases, hospitalized patients, and COVID-related deaths. In fact, it's not hospitalized patients, but hospitalized beds needed. Potentially needed during the outbreak. We can remember these successive waves and the lockdowns. So, yeah. Okay, and okay. In summary, our model has been validated also via collaborations with Polish, German, and European forecast hubs. Beyond proving scientific insights, it supported decision-making and became a trusted source for public communication during the epidemics. It has proven invaluable in shaping public discourse and helping navigate various stages of the pandemics. As we refine it, we anticipate its continued contribution to understanding and managing future epidemics. Thank you.
All right, now we are about to proceed to the next part of our discussion. Can we switch places? Yeah. All right, I would also like to introduce the fifth member of our panel, Jakub Ryzenko, is here today with us. He is the head of the Crisis Information Centre, Space Research Center of Polish Academy of Science. All right, so how are we going to proceed now? I'm going to ask all panelists 2 questions, and then we can switch to the questions from the audience. I'm going to try to make those questions open and a bit spicy, so it's going to be very interesting to hear your answers. And the first question is, right, so I think we have heard a lot about data and models and the way how we visualize that, and I think we all can acknowledge the fact that data played some important role, and models played some important role in response to the pandemic. What I'm curious to learn from you guys, what are the main challenges? So let's start in that way. What are the ways to present the data and models most effectively to policymakers? And what are the main challenges, in your opinion, in doing so? So for example, one of the early experiences that I had when presenting the model outcomes to the policymakers in the Netherlands, I had quite a number of graphs, and people were quite puzzled by those graphs. So if you can talk to us a bit more about how do you think the data and models should be presented to policymakers, and what are the main challenges, and how did you overcome those challenges? I think we can start maybe from you. Yeah, sure.
Okay, thank you very much. Maybe just as a word of introduction, I'm one of these people who, apart from just working with innovative solutions, I'm actually also, as a few people here present from Poland, we are those people who are called when something strange happens, and the crisis management people don't have a typical customized response way. So we are a kind of the tiger team brainstorming the situation. This was exactly what happened in, I think it was very early March in Poland, when we know that the problem is coming, but we didn't exactly know what it is, as anyone, how to behave. The last major epidemic being decades ago at that time. So the first very obvious thing is just to build awareness, to build a mental attitude of the decision makers that this is serious, that this has to be taken as something which can be made tangible, at least to the extent, so you can build the mechanism to gather data, to describe the situation, and you need to build it, because at least in case of Poland, we didn't have a system. It was actually the process of making it as we went, what data are gathered, by whom, how they are shared, how they are calculated, aggregated. And only then we couldn't have something which could be visualized. So first, you need to have willingness to get the data. Sounds maybe strange, but it is really the case. Then you need to get the data. You need to get the data which are somehow systematic, because you normally have some places where you get a lot of information, but this is not uniform, that the information from the leaders, if you wish, is not something that you can use for everyone, because this doesn't give you a full picture. So at the moment you establish this background, this foundation, then it was a time to talk about the form of data. And really way of using the data. So first thing was the most obvious, just visualize to understand the situation, just to have a picture what is going on. We understand better when we see it, whether this is the trend line, whether this is the map, you get the understanding of the spatial distribution of the problem. Then you went to a second step, or you want to go to a second step. You want to have the actionable information. It's no longer data. So you're actually combining data. In our case, it was combining the data about the developments of the disease with the resources on the information on the data about resources we had to deal with them. So the hospital beds mainly, equipment in these hospitals, and so on. And then you try to see when you are going towards the level where the reserve is not kept. In our case, it was 85–90% levels. This was already a red flag. And actually, we have seen this in one of the previous presentations with the blue circles getting no longer blue or even orange, indicating exactly this. But still, this is just to understand what is the current situation. So the next stage is to go forward and try to have a prognosis, and that's exactly what you are doing. But this is the adventure, if I can use this word, the mental adventure to modify the way of thinking of the decision makers, of the policy makers, who are not scientists. They are not flexible mentally to do it easily. You can achieve it, but there is a work that has to be done on this. So the first stage was really to have something which was actionable, not only in terms of the real-time response, but in terms of the planning. So there was, we've been actually as a team, we've been doing some work on vulnerability. We discovered, to some surprise, maybe this should have been obvious, that the age distribution of population is different in different parts of the countries. So as we know, the pandemic was really, at least the first wave, in particular the first wave, the elderly were particularly in danger. So it was important to identify what is the special distribution of this danger. And this was actually quite useful. In some regions, we developed this for interested regions, and they've been really making use of it. And then finally, this was happening in parallel. There was this process of reactivating your model, of supporting you, initially of building the communication with you, but then having you in a position of really providing the modeling. And then it was one more challenge to build the understanding among decision makers that now they need to formulate hypotheses, because only the hypothesis makes the optional scenario which you put into the model. So do you want to close the schools or open the schools? Do you want to keep the shopping centers open or close them? And so on. And you identify this. This goes into the model, and only then you have as a response, you are getting something which really is a guideline for decision making. So not an easy process, a psychological as much as technical. But in all these phases, having the data visualized, transformed into information was absolutely critical, because without that, you are just showing a number of digits. That's nothing else. So maybe that's enough from me for this initial intervention.
Yeah, thank you. Who would like to add? Yeah, Ira?
So thank you. I'd like to add, maybe related to the challenges in terms of utilizing data, particularly for decision making and for policymakers. So I guess from our experience, the main challenges are pretty basic for, I guess, utilizing data and transforming that into information. So first, there's questions of data availability. Does it exist? Can you get hold of it? Can you collect it? Then there's questions related to data reliability. Can you trust it? How was it collected? What is it actually, the data? And then there's particularly when we're talking about healthcare data, it's quite complex actually, the data environment and also the regulatory and legal environment in terms of utilizing and particularly sharing data, processing it and sharing it. So there's also challenges related to understanding that, the regulatory environment, and sort of how you can actually utilize it and analyze it. I think there's also questions related to challenges related to data harmonization and contextual understanding. How do you understand the data in the context? And how can you then interpret it, which is what you're talking about as well. And then there's challenges as well related to the scope of the data and what do you compare it to, for example, and particularly in a situation like this with COVID, when it was a new situation, you don't really have anything to compare to, right? So one figure doesn't mean anything because you don't know if it's a lot or a little or where it's heading. So there's also maybe challenges related to timelines and therefore to benchmarking and how do you analyze the data compared to other data. Yeah, thanks.
Any other further remarks?
Maybe I wanted just to stress that our experience, I mean the Space Research Center, the Crisis Information Center, comes from the close cooperation with the Polish Governmental Center for Security. And we and Jakub designed the dashboards for them. And this is why we have a wide experience in this matter.
Okay, from my experience, I would say that there are two aspects of this problem you mentioned about communicating the results of modeling. The first one is that you said about this, that decision makers usually aren't scientists and usually don't understand the models at all. And I think that they shouldn't understand. We wouldn't expect them to understand what's going on. And for me, there is a big space for science communicators to involve them, to mediate between scientists and decision makers. So there are professional people who are into the communication, and they are, they can do the job simply. And the second aspect is that we have many groups of decision makers, and they have, in the terms of decision theory, they have different utilities. So even general public is the public of decision makers. Should I send my child to kindergarten or no? This is decision, and they are taking the information for this decision from our forecasts published in media. So this is different thing. This is another thing to establish these utilities for decision maker for politics. You said about this. There are various aspects: health, economics, social impact. And they are not always and political, of course, goals, which are also important during taking decisions by politics, and they are not always in line. So this is the second aspect.
Yes, thank you. Sure.
If I can comment on this particular on the idea of communicating, that exactly what you said, that the moment you build you have these communicators and you already built your audience, then you need an actual technical solution to continue effectively providing the information. And this is exactly what Anna referred to. What in our case in Poland was established was that the Government Center for Security initiated operations of the GIS platform with dashboards presenting the ongoing information, because it's really not about having the information about the events 2 weeks ago, 3 weeks ago. No, we need to communicate the information about situation as it is today, the upcoming prognosis, in some cases scenarios, but however in scenarios you are very selective in what you are communicating. But what was important that there was this platform, you could see this, and what is the easiest way to communicate? By map. That's where you see it in the map. Of course, you can have the trend lines, but you can see it in the terms of the spatial distribution. You have seen this also on each of presentation. Each of the authors of the presentations wanted to show the map because they know that the map will be most telling information to any of you. And that's exactly what was the case in trying to tell something to the decision makers. Hey, this will look like this. Oops. Okay, so this is already kind of information. And of course, when you have this kind of platform, you can then play with how you are really using it. You have some information which is selected and retained only to be accessed by a small group of people, because you don't want to have some details widely visible. You have some information which are generally available, publicly available. So you have this ability. You can also have some technical capabilities like the mapping of restrictions put on individual houses, which was exactly at the level of individual houses, made available to the public services. So when fire service or police needs to go somewhere, they can verify if they are going to the safe, relatively safe location, or something which is already under some kind of restriction. This is also a kind of information flow which you can use. A detailed type of use, but also very important. Yes. So altogether, yes, build the mindset to deal with the problem, communicate, build the logic of providing information, communicate it, and then establish a technical solutions to keep communication ongoing and as recent as possible.
Yes, thank you. I think we are running out of time, right? So we are, unfortunately, I think if we are running out of time, we won't be able to take questions from the audience. I think, but I think all of the panelists will be happy to answer to the questions during the coffee break. Thank you very much for being here, for listening, and I think we can wrap it up. Yeah, and get for a coffee break. Thank you.
So as you notice also, it's not a core. So it's a core, not HERoS. But actually there are some links with HERoS, not only because of the institution, is the HUMLOG Institute and HANKEN School of Economics and Gyöngyi involved, but also on Sudeepa, who is here taking pictures, but also with the fact that in core project we use the case study, which is, not surprise, COVID. And that was work when Sudeepa transferred some of the findings from HERoS into core, and in core actually COVID is called a reference case study. So along those five cases, one is a COVID. So as you can see, even though HERoS is finishing today, some of the work which you've done is taken forward. So I'm Wojciech Piotrowicz, HUMLOG Institute, and we are one of the partners in the core. You will see at the final stage slide who is else involved, but I can also tell you that some of the partners like Italian Red Cross are also there. Is it working? Here. So today a bit about the objectives, some deliverables, what is already done, an example of the deliverables which we as HANKEN, of course with other partners, were working, looking especially at the preparedness. We try to look forward based on what we already learned, with a focus also on Finland as kind of best practice or case, as we even just discussed during the break, that some countries are looking at the way how Finland arranged its preparedness. And also you can follow the project, and you are invited to our webinar on the 14th of June. So in the core objective, we have this crisis modeling framework. We have about indicators, the weight of the human factors. There is kind of heavy put on the human side, on the social side of the crisis response, and crisis preparedness and the resilience. We have the social media, so not surprised, similar as here, we will talk about the use of social media and this information. This element is also there, included. Of course, not all cases, because some of the cases are quite old and are in different languages, so that creates certain methodological problems. And we have some guidance materials, such as there will be some courses, videos, and so on. So where are we now? We are more or less halfway through of the project. And we have already those deliverables. They are not public yet, because we're waiting kind of for the final approval to have them out. But we have this scenario analysis framework. That was the framework which was used, kind of standardized, looking at the cases, which I already mentioned. So the case study identification. So there are cases except COVID. We have also forest fire. There is a terrorist attack in Manchester. There is a flood, for example. There is industrial accident in India. So whole kind of mix of both natural and man-made disasters. And then we have also this, which is the brief of preparedness and security of supply. How to look at the what to do to keep things running, to get stuff to people, to have the goods delivered. There are also this safety culture measurement toolkit, and actually safety culture will be something which is also one of the topics of the webinar on the 14th of June. So, but you see those kind of very soft elements of preparedness, looking at the societal part of the societal resilience, and also about the communication patterns. So this stuff is kind of being to be released very soon. And this one we have this, our task was supporting societal resilience to security of supply, that we are the leading, we are leading here with Sudeepa doing the lots of work in this, bringing also stuff from HERoS here. And we have the comparative analysis of the case brief of preparedness and security of supply in month 18. And what we did actually within that, we look at how security of supply is prepared within disaster management and DRR frameworks. And we look at the cases of several countries, means Finland, Sweden, Italy, and Austria, with actually Finland and Sweden being considered as leaders in preparedness due to the total defense concept or the whole of society approach, which was not always the case in other countries, especially after the Cold War. So we look at the things such as prepositioning, training, framework contract, supplier management, and how those are related to societal resilience. Here, of course, you can add that it's not easy because, firstly, it's a very dynamic process, as Gyöngyi was mentioned about the impact of COVID research on preparedness and prepositioning. So, for example, we have now ongoing DG ECO programs on preparedness and prepositioning, and also the conflict in Ukraine changed quite a lot the dynamic and the way what organizations and countries are preparing for. And of course, the COVID was the first kind of trigger of the changes, while the conflict and follow up the energy shortages and parts shortages and so on was the kind of second trigger. So this is really dynamic situation. So even though this work is supposed to be finished, we'll still keep our research because I think it's really kind of good opportunity to see where we are going and what is triggering what are the relationship between what's going on and how countries are responding. So we'll be working now, we have conference papers in work, and we work on the journal articles. So the kind of first way in this report, it was, unlike you just mentioned, all those models. We look at the qualitative, means we look case studies, which I will provide pretty good input later if somebody wants to do the models. So primary, secondary data, and look at around 26 interviews across those 4 countries, with majority of them being in Finland. And in Finland, I would say it's a really interesting thing, but it's a system of preparedness. We don't really talk about the single institution. It's a system which is composed of authorities, private entities, academia, and so on, and also NGOs. And so what we can, without going kind of into details, into the content, what were kind of the key conclusions from this preparedness exercise, the analysis of the way how or what you can do. So one of the conclusions really that you need to be prepared for all scenarios, and that's kind of really good to see going at HERoS and pandemics. You know, when the pandemic started, I went through several documents in different countries. In every single one, there was pandemic or something called very similar, because some countries divided it into, you know, some of them were natural, some of them may kind of artificial or terrorist-based attacks. But everybody was talking about pandemics, but really the scale was kind of, okay, surely it will not happen, as you have this slide on the black swan at the beginning. So now you have to really say someone, you know, it may happen, it can be the worst scenario, and you really need to think about that in advance, because later can be simply too late. Multiple risks, again, for different reasons. We can see here, for example, clear difference between Sweden and Finland. When you look at Sweden, what is communicated to the general public, even title of the leaflet which was delivered to every single household was "Be ready for a crisis or war." So they have clear mentioning the conflict, possibility of armed intervention by external powers, not named that time. But it's not at all, for example, in the Finland. It's just a crisis, mainly natural. And lots of research also, when you look about DRR frameworks, for example, the DRR framework don't talk at all about conflicts, because those are different mandates under different organizations. So really about this kind of multiple risk consideration. Yes, hybrid attacks, hybrid threats, those are now, for example, coming into DRR frameworks. When the Finland was under DG ECHO, that was discussed. So conflict, direct conflict, full-scale conflict, partial conflict, hybrid, and of course natural disasters are still happening. Mass movement of people is going on. When we have influx of people from Ukraine, refugees, it doesn't stop at all the movement of people from Middle East or Balkan route. And we are kind of tend to forget about it, that the things can be activated again, for example, by opening borders by Turkey. So really it's about thinking about those all scenarios, multiple risks, not saying kind of the wishing for the good. No, it's the other way around. Plan for the worst and hope for the best, simply. Then about this kind of polycentric systems of systems. So not to create this one single huge system, which is countrywide, but have subsystems. NGO subsystem, academic subsystem, private sector subsystem, which are working together. So this is about this kind of integration of different stakeholders. That's the stakeholder conference of different stakeholders into the preparedness in response, and practicing that, because you cannot wait for practicing when something happens, because everyone is busy running around solving the problems without time really to plan for it. And also this important issue about evolving households and individuals' preparedness as part of the life routine. That was quite well said about people being decision makers based on your COVID, sending children or not, going to work or not. And that really is about preparing people, giving them information in advance. And like in the case of Finland or other countries which have this type of direct communication with citizens using different communication channels, we are also studying that, comparing Swedish approach with Finnish one, that government authorities are saying clearly, people, you need to be prepared yourself, because in our current situation, if something happens, we cannot help you for 72 hours, that's the title of the campaign in Finland, or 1 week, like case in Sweden, which at the beginning there was actually no date, later they say. For that period of time, you need to have food, water, energy, your pet food, your medicines, and so on, because state resources will be directed somewhere else. And I think this is an important message, that people have to take also responsibility for what the whole society is doing. And when you start to send this type of message during the crisis, that actually spreads the panic. We could see it already when in Sweden the first leaflet was issued. We interviewed people before the COVID, and there was, okay, government probably knows something and they don't want to tell us. So they're delivering this leaflet. So you have to have all the campaigner kind of countering the disinformation, really saying why you are doing certain things. But it's about this involvement of household, individuals. So this kind of preparedness is not something which brings this fear. It's not bringing the element that something may go wrong. No, it's part of what you do. For example, also we have the part of that was the HERoS. We have the HERoS Science Center exhibition prepared by HUMLOG, by our student, by Gyöngyi and some other people. And that's directing children and preparing them already from a young age how to cooperate in preparedness. I think this is also important, that people have this kind of, from the movies, the lone wolf approach. You escape somewhere and live alone. No, preparedness is about cooperation, it's about helping others. And that's kind of frequently missing from all this discussion. And also important for our part means the supply chain is about keeping supply chains running. There again, we've seen some tendencies that government or other institutions, okay, we will replace whatever is going, it will duplicate, about this facilitation or duplications. Are we kind of creating the system which is stepping in as a kind of second layer of a supply chain, second flow? We create totally new one which will replace the old one, and it will never work, simply because you cannot be better than professional supply chains organizations which are doing it for decades. They do it all the time and do it the best, and their core work is exactly keep supply chain running. So role of the preparedness, role of the state, role of the authorities is really to help them running those supply chain, not to replicate that, not to duplicate it, creating alternative option. It's about really providing them with knowledge, with training, with exercises, so they are working together and getting prepared for something what is happening. This actually this private sector competition. So this is case in Finland, when competing organizations which are normally on the market playing against each other, trying to get customers, sit together because they know if there will be hit of something like COVID or sanctions or something big at the country level, everyone will be impacted to the same level. So there is no point to compete. So let's sit together and try to find out what are the solutions for whole industry, for whole sector, not for individual companies. And that's something actually one of the NESA organization is doing. They are bringing, they have 11 pools and bringing companies from one sector on the other and sit together and have exercise. And that's on the voluntary basis, because organizations also see value in that, because that allows them to change, to improve their own preparedness, and also the risk analysis, which are from the top level, are going to the companies. So that's kind of win-win exercise. And now this is going down from the country level also to the regional networks. So those organizations which are not critical for the country, but are critical for the region. So now it's kind of going down. Because what we identify, like you have these kind of household individuals, you have here kind of preparedness at the country level, and the key companies, there was not much initiatives working with, for example, small businesses, restaurants and this type of small businesses, which are actually base of every economy. To what extent they can be prepared. And they are really important because they have resources, which are really decentralized. So this is about this issue about really facilitation of preparedness instead of trying to duplicate, recreate the existing supply chain and stepping in instead of supply chains. Because those are running, during COVID, shops were open when there was no lockdowns. During the conflict is the same. I just heard, in the Bakhmut, 6 kilometers from the front line, the shops and post office was still open. So people are just running the things as long as they can. In Syria also we could see this, that if there was no shops, there were local traders. There were simply, people are taking those opportunities because they need to live simply. They need to earn, so they are doing whatever they have to do. And about this cooperation and competition, you don't work, you cooperate. And also, of course, don't forget the civil society organizations, NGOs. Here we have Project Hope, PCPM, Red Cross. Those are really critical. And also, again, there is misconception that this type of organization doesn't mean they are not professional. In some countries say, okay, NGO cannot be professional. No, this is really important. You have to, again, bring them into place early enough and also establish communication and their role. So again, you need to do exercises, joint work together, knowing each other. And so those are kind of basic conclusions from this report, which is supposed to go in this form, but as I said, we are still going on with research and hoping to improve it. The second part was about the cascading effect, about supply chain disruption, about the problem definition, variables, that's the methodological part, about the code. But this is about, again, system dynamics model, looking at the causal loop diagrams and the relationship between the elements. And here really, this is kind of top view. Of course, you can zoom it to make it more understandable, but here you can see the complexity of the relationship, first level, second, third level effects, connections between elements that, by closing, for example, nursery schools and primary schools, people have problem to, they have to stay at home, look after children, so you are losing key workers. So you cannot operate your infrastructure or your hospitals because people have no place to leave your young children. And that's something we are kind of rediscovering from, because this stuff was, for example, during civil defense or during World War II already there. And as was mentioned earlier, the decades passed since the last conflicts and last disasters, we kind of forget those learnings simply. So we need to learn them and also put them into this kind of new context, new technology, new societal structure. So here I'm looking at this kind of nexus of the food, energy, water, health, and critical infrastructure. And this is also kind of interesting because we were here kind of step ahead when we look at the latest changes in the European legislation. I would like to name here the critical enterprise, the CER directive, critical enterprise directive. So when it's changed from the critical infrastructure, means the pipes, factories, bridges, into this more supply chain point of view. How to be sure that we are able to provide services into society. It's about the service continuity, not about the infrastructure anymore. And this type of work kind of is supporting it. Okay, so that's the invitation, 14th of June. That's the safety culture, that's the preparedness webinar. So I hope You will be able to join it. You can also see the older events recorded and follow the project, the web page, LinkedIn, newsletter. I think the presentation will be available, so that will go to, you can click it. And here you can see the partners from this project. So thank you very much. And of course, I'm here till end of the day. So we can, if you have questions, I'm available. Thank you.
Okay, thank you, Wojciech. Welcome to work package 3. We're going through 4 deliverables. So I will start the first one, and then we move with the Greg, and then I will be back for the last one. So our work package is mainly on medical supply chain, securing medical supply chain to respond to a pandemic. And then we cover these 4 topics. And then I will start with gap analysis and recommendation for securing medical supply chain. And then we move to the drone side, which is the first part of it is adoption of workflow for drone deliveries to quarantine drone, then demonstration for drone deliveries, and then the last one, economical impact, or a highlight on economical impact of supply chain disruptions. And then let me move first for our first part, which is the supply chain or medical supply chain. And we are trying to highlight what we have learned from our deliverables and what we have done during the project. First of all, healthcare industry, it has its own characteristic. I mean, it's overwhelmed by regulations and policies at national levels or global levels or even at the industrial level. I mean, it's not like any other industries, although other industries have their own regulations, but the healthcare industry has more restrictions and regulations. When you look at, for example, the requirement condition for transporting any medical, for example, drugs or medical equipments, or even the standard of productions of those medical equipments or drugs, or even the custom clearance of any medical supplies, all those things are really burdened by so many regulations. So you can imagine that during a pandemic, really that became an issue in addition to a pandemic itself and the regulations or bans and restrictions of the pandemics. And also, medical supply chain is global. I mean, the need is everywhere for medical supplies, I mean, across the globe. And also, the demand is everywhere, but the production and the production capacity and the scattered of the manufacturer. I mean, when you look at the globe, for example, look at the PPEs, you find that most of the PPEs came from certain companies at some stage, which is mean the productions will be somewhere. If there is a transport ban or any restriction, definitely the whole globe will be affected due to that one. But if equally the productions were there in different areas across the globe, so we could see a bit of flexible supply chain, or we can at least find some solutions for that. But if most of the production came from Hong Kong, China, Malaysia, and some from United States or Canada, then the whole globe will be in trouble. When you look, for example, at Africa or Middle East, then you find there's like a huge gap of productions in medical supply chains. And also even in Europe at some stage, there were like some issues with that one. Travel bans or travel restrictions also raised like a two-edged sword, we can say that, because that locked the border and then stopped the movement of most of the medical supplies. But at the same time, that came up with the new maybe drone deliveries, beside also air freight. That's became another options or another solutions, and that's why we have drone demonstrations here and their own simulations here as well. So when it comes to the disruptions of supply chain, immediately when COVID hit, the global then supply chain immediately affected by COVID due to many things. I mean, people started to buy the stuff panically, or start to hold some items. Besides, nations and countries also started to keep some items or even prohibit some items to be exported. That's at the later stage. And apparently we can see that during the vaccination time. So, but let us look at the direct effect of the supply chain disruptions. So you could see a lot of direct effects on the medical health facilities operations, and also you could see another effect like policy induced during the disruptions or to respond to the disruptions, beside also pandemic-induced behavior of the decision maker or the behavior of people, both of them. So also we need to consider the decision maker behavior also. That's very important during any pandemic, because that could add more consequences beside the consequences came from other stakeholders. Also supply chain strategy during pandemic. I mean, we need to change the strategy, or people and countries started to change their strategies to deal with the new pandemic. Then you need to look for reassuring or whatever strategy that could be one of the solution. So the main highlights out of that, the healthcare capacity is not just ICU or bed. Also, we need to look to other resources and facilities. So you could have some ICUs and you could have some beds, but you need to look for also professional side. So do you have a trained staff? Do you have well-equipped staff with skills that can fit a pandemic? Yeah, you can see that during the pandemic, most of the healthcare facilities has some issues with dealing with the staff, flexibility, staff shifting, and all those kind of things. And then when the staff themselves get affected by the pandemic, so you need to find a solution. So I think that there were like nobody fully prepared for this kind of situation. So we started to learn from COVID that's okay, it's not only about ICU or beds, but also other matters need to be considered. Then transportation capacity, especially cold chain or refrigerated, also transportation or containers. So you need to consider that, because to move anything related to medical supplies, you need to think about those in a serious way. Interdependency of the critical path, and also competition for items. And apparently that pop up during the vaccinations when vaccine started to come out. So nations started to behave in a different way. Then that's also another issue. We need to think about it. Again, even PPEs also became an issue for so many countries because they were not having enough stock, and then other nations started to prohibit that or to ban the export of PPEs and so on. So all these highlights need to be considered in any future pandemic. Okay. Then finally, we had these recommendations or these lessons from COVID. We need to, first of all, get prepared, and then standardize, and then innovative and collaborative. You can think about preparedness from different point of view, if that proposition or joint procurement or framework agreements. So when we talk about joint procurement, for example, so there are like so many initiatives across Europe or in other also regions. So those initiatives help in at least observing some consequences of the pandemic related to procurement. And also, that's one of the, propositions. So you could have some agreement or collaboration in procurement. And I think we learned a lot about that. And there is a COVAC and other also joint procurement agreement. Prepositions, so you need to get prepared for that, not only in terms of COVID items or COVID-related goods, but also in terms of other stuff that's required for operating healthcare facilities or for providing healthcare. And also standardization, kitting for the interdependence item that could save a lot of time and money, and also that could facilitate it more than before. And also global certification and quality related to items, medical supply chain or medical items. Also, there is like some issues with the standardization. Then people, they may need to come with a standard for those items, which is may also facilitate or help a lot in overcoming some of the pandemic issues. Then innovation. So we agree that innovation is something forced by nature. I mean, by nature, we mean that since we have industries, since we have needs, since we have problems, so innovations will come. But we need also to find a structured and flexible way to innovate and to create new products or to create a new services or new ways of providing services. And then collaborations in different way and at different level. We know that everybody talk or has a collaboration at some point. All of us, I mean, as organizations, as nations, or as countries, they're like sort of collaborations, but that was not enough for the globe, since the pandemic showed us all, taught us a lot about the collaboration. I mean, we could do it better than what we have done, because there are like so many ways, so we can come up with the new collaborations also that may help the globe to overcome any threats in future. This in general recommendations and sum up or some learned lesson from the pandemic, particularly in the medical supply chain side. This is just an attachment show us sort of a cascading effect of the disruption of supply chain. So we could see from international travel ban, and then the flow of the consequences, and positive and negative, I mean add or minus to the consequences when you look at this. A bit complicated and unclear, but the takeaway from that, there are no local medical supply chain. Medical supply is global, medical supply chain is global. So nobody can think about that at the global level, and then that should be the new lesson. And also, it's all about the loops. So no mitigation strategy work alone. That means we need to think integratedly and to think also holistically, because it's not only a matter of supply chain strategy. You could adopt, you could implement one or two supply chain strategy or a combination of supply chain strategy, but that doesn't work at all, I mean, every time. So you need to combine that with other policy, regulation, other strategies, collaborations, innovations, and preparedness, and so many other issues need to be considered. This can be considered as takeaway from supply chain or the cascading effect of supply chain disruption. Also, out of that, we just had this before, the temperature control of vaccine. So the takeaway from that, holistic perspective is needed. It is not only matter of the temperature, or it's not only matter of cold chain, or you have a refrigerated container, but need to be more than that. Also, we need to focus on material handling point, and also no nations can wait until you get the infrastructure or facilities of vaccine or of any drugs or medicine. When the medicine or vaccine is just came out, that means that vaccine should be delivered to those who need it. If there is no infrastructure or there is no cold chain or whatever, then nobody will wait until he die or she die because the infrastructure is not ready. Then that may need also to be fixed or figured out. Otherwise, nobody will wait for that. And also the ultra cold chain, although we had experience with so many other diseases, but still the preparedness, a cold chain, refrigerated, also container or other modes are still need to be considered and solved to be fitting, or at least to respond as we expect or as we wish, and then to overcome any threats related to pandemic or any other issues. So that was the first deliverable, which is related to medical supply chain. The second one will be with Greg, drone. drone simulation and drone demonstration. So Greg, the floor is yours. Thank you.
Okay, thank you. Okay, I think this is the same presentation, but the next slide. No, the previous one. Yeah. Yeah, we need to come back to the previous presentation. Yeah, that's correct. Okay. Dear, I'm Greg, as you perfectly know. And I will show the brief results of our project, HERoS project, regarding the deliveries of medical supply using the drones. And we start from the very beginning. So we start from the simple question, why the drones? And the answers you can see here are only the part of the problem, because the big answer consists of several levels of the answer. First of all, why the drones? Because Darek, who is sitting here, and me, we are the drone guys for more than a decade. So looking at the problem, we are basically looking for the solution regarding the drones. Okay. The second point, the second attempt to the answer is that we both are approaching the deliveries of goods with the drones since 2017. Wojtek was also involved in our first project when we apply for the delivery using the drone, the delivery of goods through the Baltic Sea from Poland to Finland. Yeah, that was 2017 or something like that. And finally, the HERoS project appeared. So we went into this project from with the basic preparation of theoretical works, how to deliver the goods, how to deliver the medical supply with the drones for the long range flights. So, coming back to directly to the project. So, when the project appeared, we thought, yeah, okay, we can do that with the drones. We also are looking at the drones as not as drones like, the flying robots. We are looking at the systems as one of the branch of modern aviation. That's why here internally we are calling it unmanned aviation, not the drones. And regarding our project, regarding HERoS project, the drones or delivering or regarding the humanitarian aid, regarding the medical aid, drones are giving some advantages, like access to quarantine zone. And this is something we can think, okay, this is a drone, there is no human on board, so we can fly the drones, that could work. But basically, what we saw last years, we saw this in a praxis. Because as you remember, that was 1 month or something like that, when UK banned all flights from Europe or from continent to UK, all flights. except unmanned flights. So that was the very small step, but very significant, that the state itself allows to fly with the drones and ban the manned aviation. Okay. So the drones are giving us, and we saw it on our own. The drones are giving us the possibility to go to the quarantine zone or to go to the zone which is isolated without involving the people on board, which reduce several risks. And the risk of contagion is one of them. The second one is a risk of aerial accident. The next is the risk of spreading the problem around. Okay? And what is the contribution of HERoS project regarding the drones delivery? So, starting this project, we were in front of a big change in the drone industry or unmanned aviation industry. We were in the face of new European rules of flying the drones. That's why at the very beginning, a lot of people wanted to see flying drone or the drone flying with the cargo. And our approach was a little bit different because we knew that these new rules can stop flying the drones for the several months or several years. We were focused more in this project on a chain of drone delivery than, to build up the small drone and fly it around the head. So we were focused in this project. We were focused on a system of delivery, or logistic system of delivery of medical supply, more than the drone itself. That's why we focus on a workflow for drone deliveries, of course, in the medical items, and we took into the consideration like materials handling, temperature, vibration control, reception of qualified personnel. So technical consideration of flying the long-range UAV. And we were also focused on physical abilities of the pilot when flying 4 hours, 6 hours, 8 hours in the air. It opens the wide doors of the new knowledge about the UAV pilot in the long range and long time flights. We also took into consideration human resources problem, like how to ensure the operation of medical supply in, for example, half a year. How many pilots do you need? How many technicians do you need? How many drivers to deliver medical goods to the forward operating base? Okay? So we were focused more on the system of delivery than the small drone with a small package. And we also took into consideration the legal problems. Because, as you know, the drones are a part of our reality right now. So if you are going somewhere, you can see the drone. This is not something unusual. All the news have pictures, have movies from the drone. Okay, so the drones are part of our reality. But the problem is we are not talking about flying around the monument, for example. We are talking about serious job. We are talking about medical good delivery, including cross-border operation. So we are talking about big airplane, which is 600 or 700 kilograms of takeoff mass. So it's not a drone like with a photo camera. Okay? So and this problem and this approach causes a lot of questions and a lot of answers. That's why in the HERoS project we went, as I said at the very beginning, we went more on the system and more to find or anticipate the problems and find the solution, like organization. Because today, we are in the time that this is not a problem to take 100 kilograms and put it or take it 1,000 kilometers. We are able to do it technically. But the question and the problem is, we are not able to do it in organizational manner.
Yeah.
Okay. So here you see the flow of UAV delivery, the big UAV. This is 150 kilograms UAV, and in the HERoS project, we prepared the concept of the airplane, the concept project, which is a first phase of typical aircraft design. So we took it and put into virtual reality. And we built the UAV control station, and we built the simulation of a logistic chain. So, and you can see a part of the system in the lobby. So during the break, please come, and you will see the initial concept of the airplane. But coming back to the slide. Here you see the flowchart, and there are three basic lines. This is the orange is medical supply requesting entity line. Basically, we call it hospital. So hospital is calling for the medical supply. The decision is made, and the green line is a logistic line of the preparation of the good, of the cargo. And request is going to the hub, cargo is being prepared, cargo is being selected, cargo is started, doing all the logistic papers from the warehouse to the truck and sent to the loading area, checking, sealing, customs, very important thing, and this is the problem we were faced. Okay, if we want to do the cross-border humanitarian operation, how to ensure the custom? How to ensure that the drone delivery is not used for the traffic? So this is the serious problem because there is no man on board. Okay, okay. Finally, the flight line. And these are the main points. What should be done in this flight line to ensure the flight? So the cargo flight, the medical supply cargo flight. So starting, I don't want to say point by point, but look at this. And if you went or if you go for the materials from this conference and you look carefully through this, and you will compare to the traditional pilot job or traditional flight job, you will see that flying with the UAV and flying the traditional means manned airplane during the medical supply, they are similar. That's why we are talking about unmanned aviation. We are not talking about flying the drones. And this is one of the crucial conclusions from this project, which is personally for me revolutionary regarding the drone industry. And the last point in the flowchart is mission, closing the mission and preparation for the next mission. But this flowchart, this activity, cannot be if we don't take into consideration the stakeholders of a drone delivery, drone medical delivery. And starting from the very beginning, for the system of drone delivery, system, not just flying the drones, the agencies responsible for regulations need to be involved on the country level, means national level, but also on the international level. Because, as I said, as you know better than me, the humanitarian operation could be cross-border operations. So there is a need to have regulatory agencies, airspace management agencies involved in the system. Logistic service provider. Logistic service needs to be prepared that the system, that the cargo or medical supply will be sent via drone. Physical infrastructure like airfield, like operating base, like landing points, everything needs to be prepared for the delivery via drone. Dangerous local public areas, dangerous good, hospital. So this what you see is a result of pinpointing the stakeholders from the simulation we made. Okay, and what you see here and what we did is a world-first medical supply digital twin. Because we focused, as I said several times here, we are not focused. This is not a simulator of the UAV. This is logistic operation simulator. So I would call it digital logistic operation or medical supply operation digital twin. And we start, and we did several tests, like how to fly, how tired you are after a few hours of flight. We did also the research how the indicators are to be put on the screen to not to get the pilot tired more than because he's sitting in front of the screen. So the payloads for the or UAV characteristics are prepared initially, like 150 to 200 kilograms of payload, distance over 1,000 kilometers. Okay, and battery power, yes or no? It's during the project we went into conclusion that the other means of other engines are better. Technical limitations during the simulation, during the delivery, but all of that make us several, let's say, conditions which are to be fulfilled because those operations come into life, into reality, and some challenges needs to be solved. So going shortly, the legal conditions, drone regulations are to be worldwide. For the, of course, humanitarian operation or medical supply operation in humanitarian operations. there need to be some standards. We can call it certificates, but there needs to be some standards because the delivery system needs to know, for example, that this pilot is sufficient to go in this operation. Okay? And the technical conditions needs to be ensured, like security conditions, cyber security conditions, operational ability of the pilot. One of the very important and very difficult question we were faced during the project is how to check if the pilot is not drunk. How to check it if you have a pilot in Thailand, for example. Okay. And the challenges the drone deliveries are faced. Lack of clear governmental policies, governmental for the humanitarian operations, and governmental regarding the international operations. Because right now, all of entities are focused on the very, very small drone, comparing to our. Security threats and unsafe operation. Every flight operation is dangerous. And the most dangerous are the operations where there is no pilot on board. Okay, recommendations from our project. First of all, we need to standardize air traffic rules for bigger or big drones deliveries. We need to go as close to the traditional aviation as we can. Second, we need to take care about the cargo regarding the illegal activities, because drone can be used for that. And we need to be prepared for such activities, or to do or to prevent such activities. We need to have standards that the system, for the liability of the system in terms of traditional aviation rules. And traditional aviation rules are the rules which cost lives because of history of aviation. And last is we need to specify the rules for the flight. We need to specify the rules for the aerial operations using the big or medium size or big size UAVs in the organizational manner. Yeah. So that's the end of my part. The questions? Yes. Raz. Okay, see the microphone.
So, just I wanted to share an observation more than a comment.
Oh, thank you.
My name is Wojciech. I'm the head of PCPM, and we've been in touch. And I'm also very grateful for all the linkages made during the HERoS.
Microphone.
I was initially, to be fair with you, I was initially very skeptical about your ideas and the drones and the deliveries. Well, mea culpa, right? I mean, I was skeptical. But just to give you a heads up, we're currently in a discussion with the European Commission that PCPM would operate a warehouse of medical supplies in Nairobi, in Kenya, for the support of emergency operations in Africa. And with such a warehouse, and the warehouse of predominantly medicines, what you're talking about, and the use of drones of 150 to 100 kilograms, then out of a sudden becomes a very good idea. But also what you mentioned, that the lack of the international legal framework in how the drones should be should be utilized, it's even more pressing, because it's not only about the whole aviation law and how the drone flies from A to B, but even what should be the custom process of bringing, let's say, medicines from one country to another if they are transported over the drone. So I find your work really, it's like, I hate this word in English, but thought-provoking. But indeed, it really nicely, I hope that one day in the future it's going to translate into something of operational use, especially in Africa. Thank you very much.
Yeah, okay, thank you. That was very nice to hear that, because what you said is, me personally, is like, you know, to confirm that the way we started 5 or 6 years ago was correct, and our line that the drones are the next stage of the aviation is correct idea. So yeah, thank you very much. Thank you.
Juggling the microphone will be easier. Jakub Rysenko again, but this time in slightly different context, because we happen to be also a leader of the activity which is conducted under the umbrella of the DG ECO, Union Civil Protection Mechanism, exactly in the context of drone and what Wojtek was talking about, that one of the challenges that the activity has is to identify the air traffic management, or in general, the different systematic principles needed for effective use of drones, not only here for civil protection in Europe, but also for the other activities where DG ECO, so European Commission in general, is involved in international humanitarian activities. So I think it's quite important that these kind of thoughts are really present on the table when these things are discussed. But I'm not here only just to make the invitation, which I, by the way, made, but I think it's also an opportunity to make a comment that the usefulness of drones, I think, is already proved. We see a lot of situations where they are making a difference. But from what I'm hearing from your presentation is that you are looking at the permanent solutions. It's a very nice thing, but it will not work for a long time. And that way we still thinking and having the permanent solution as a goal, we also need to identify and implement an intermediary solutions. So we can use the drones as soon as this is possible and safe, because those medical supplies are needed. Those drone operations are conducted anyway, but they are just not done in a safe way. So instead of looking at the idealistic long-term goal, keep looking, but at the same time, see something smaller, which we can achieve faster and make the operations effective, enable really them. Because in some cases, what we are needing is enabler.
Yeah, thank you very much. And just to let's say answer for that, we found the midterm solutions, but we were not focused on building the platform. We were focused more on, for example, pilot working conditions. And from this point, we, for example, developed the tests, how to qualify people for the job, for being a pilot, cargo UAV pilot, in an efficient and safe way. And our assessment is that there is a lot of entities building the UAVs. They have engineers, etc. We were focused more on the pilot working conditions and the ground control station to be comfortable and safe for operations. So this is our approach, and this is our midterm goal. And we are also trying to find the entity who is, or which is able to build the airplane itself. But from our perspective, we are focusing on the man, on the pilot, because as far as I'm concerned, a man, as a mankind, yeah, a man needs to be in the loop during the flight operation, during our aerial flight operations, because of whole aviation rule that somebody is responsible for the flight, and it cannot be a robot, it should be a man. Yeah? Okay, I'm here. Thank you, getting credit. I'm here all the day, so if you have any question during the break, etc., so yeah, please approach. We can talk. So thank you very much for your attendance. Yeah, thank you.
Okay, so the last presentation of this morning. So I hope everybody's ready for that one. It's going to be a bit technical. Hopefully it's going to be fine. My name is Gregoire Burel. I'm from the Open University. And what I'm going to present is the work we did as part of HERoS for tracking misinformation as well as understanding how it's spread on social networks, and as well like our kind of experiments to try to affect how it spreads. Okay, so as I was just saying, we're just going to cover 3 parts, which kind of go from basically the first part is to monitor or misinformation appears on social media. And for that, what we're interested is to know how we can track it, and as well how we can visualize it. And that can be used, for instance, for fact checkers or organizations to know what is the situations, for instance, about misinformation during pandemics. The second part is to try to better understand how misinformation and as well the fact check that try to correct this misinformation spread together, and understand who spreads that information and misinformations, and what's the impact of fact checking during pandemics. And the last part is we want to know if we can influence how that spreads by basically pushing fact check to people that spread misinformation. And for doing that, we used 2 different tools that we developed. One is the fact-checking observatory, and the other one is the misinformation tool. And the fact-checking observatory, there is a demonstration as well, if you want to look at it later on. So as you know, by now, during the pandemic, a lot of misinformation was spread online. And although fact-checker ramped their work to try to address the misinformation that's spreading, and they kind of produced more than 16,000 fact checks. Still, we observed that misinformation was spreading twice as much. So what we wanted to do is to try to monitor that information and to see if we can influence it. And as you can see here is a map that shows where misinformation was shared from. And you can see end of January in 2020, like when basically the pandemic picks up and no country didn't share misinformation pretty much. Okay, so the first part of monitoring, what we did is we created a database of fact check and misinformations, and then we kind of look on social media, which is on Twitter in this case, for mentions of that misinformation and fact check. And then we created a website that kind of generate reports for that information. And the second part, we did a study of how that misinformation fact check spreads, and particularly we want to know the topics that spread the most, for instance, and if they spread differently depending on the type of topics that are involved. And as well, the big question is, does fact check impact the spread of misinformation? And the last part, what we did is we created a bot that basically will tweet back corrective informations to people sharing misinformation, and we try to identify what type of messages might be more successful there. Okay, so the first part is about monitoring. So obviously, for doing all those analyses, we need to get that data. And what we do, we rely on something called claim reviews. So claim reviews are basically like a structure format of fact checks that fact checkers share online, and is used by search engine, for instance, like Google, to present such informations. And so we collect these informations from various sources, and then basically we track by querying Twitter to see who shared them and how many times and so on. And all this data comes from the International Fact-Checking Network, which is kind of big organizations that have signatories, and they have some guidelines to be part of that organization to make sure those fact-checks are actually reliable, because there are some fact-checkers that are actually fake fact-checkers. So as I was saying, so what we do, we collect that information, and we continuously try to get on Twitter the mentions of that misinformation and fact check. And then we augment that data with, for instance, by doing automatic demographic extraction, for instance, to know like the age or like whether the account sharing that misinformation or information is an organization or not, and so on. And then we get a database. And yeah, around 16,000 fact checks, and then around 500,000 of tweets we collected using that technique. Okay, so then what we did is, using that data, we collected it and we created a website that's called the Fact-Checking Observatory. And what it does is not like a standard dashboard. So what it does is kind of create snapshots every week of a situation. So the idea here was to not try to make like, let's say, like thing with a lot of buttons and things like that, more like a way that fact checkers or organizations that want to know what's the situation could just look at the reports and they like every week to know what's going on. And it contains like 3 types of content. So you will have informations about the key content topics that are shared in a given week, as well as the coverage, like where fact checks come from and so on, and as well as the impact on various demographics. And that again can be used for fact checkers, for instance, to get a better idea of what fact check might work or not work, and as well where misinformation probably spreads the most, so they can potentially target better their fact checks. So there is 3 types of pages on that website. So first, usually you have the home page that kind of gives you general statistics about the data we collected. The second part will be timeline, so you can see all the reports that were generated and basically read the one that interests most. And the last part are the report themselves. So the reports, as I mentioned, contain a few key points, and they're generated automatically. So first, you will get an idea of how misinformation, for instance, has been changing over the past weeks. If there is more, like compare, so you get some idea of trends. Is it increasing or decreasing?
the other part, then you will get ideas about the topics that have been shared the most over time. So, for instance, like here about authorities, and as well how it's been evolving over time. And that again can give an idea of what are the trends in there. And then finally, you get like this information of what are the top misinforming content for a given week and how it's been spread over time. The same for fact check as well. And then you will get also ideas about the coverage of the fact check themselves. So what language they're covering, where the organization are from. And the other part that is interesting as well is you are able to know what are the distributions of fact check compared to misinformation spreading, and as well demographics of who spreads that information. And there will be a demo, but basically can be accessed. The thing that's important to know now that actually we collect, because there is less and less fact checks around COVID-19, even the pointer database now is not updated anymore. We actually now collect also misinformation around the Ukraine war, so we have like a new section on the website. And quite a few future work on there as well. So now that we have all this data, the question is to understand who exactly spreads it and what's the impact of the fact check for the spread of misinformations. And what we did, so we did a large study collecting data from the beginning of the pandemic until the January 2021, so that's kind of a beginning, first year of the pandemic kind of analysis. And what we did is we tried to understand how if misinformations and fact checks spread similarly. So we divided from the first time misinformation reappears, from initial period, which is the first 3 days of that information or misinformation appearing, then early sections for 10 days, and then the long tail. And we want to know how it spreads over time and what are the differences. And what we observed, so if we look at the demographics, for instance, of who share that information and misinformations, obviously we see that more misinformation is shared, which would be expected. And for instance, vaccines as well is a quite type of misinformation was shared a lot. So how do we identify the topics that we want to analyze, for instance, for those classifications, so for those analyses? So a way of doing it is to, for instance, in terms of data analysis, would be to kind of ask individuals to annotate that data, and then we will train like a model that will be able to classify new data, and then we can basically scale that. And what we observed is actually it's a very hard task because the topics are very related. And what we can observe is when you compare fact checker and machines, they might not classify the same way. And actually, we did some tasks with humans annotator as well, and they were not agreeing very often. Fortunately, we have that issue, but fact checker themselves, in terms of that specific database, annotated the data themselves, so we don't need to rely too much on those models. So now if we look at how misinformation and fact check spread overall over time, so obviously we can see like 3 sections of how the misinformations was ramping. So at the initially like very small, and then suddenly like exploding, as you could see from the map at the beginning, after like March, and so March, April, it started to take off in 2020. And if we analyze if we compare, for instance, for the same type of misinformation, the misinformation and the corresponding fact check, or they spread during the 3 different periods after they appears, what we see is like initially they spread very differently, and as well on the long term, while in the middle they will tend to spread similarly. So what does that mean is most of the spread in general appears initially, and there misinformation will spread much more than fact check, and that will happen as well again much later in the life cycle of misinformation fact check. And what that means like in the late period, so like if misinformation initially spread and then 10 days plus will reappear, so misinformation will share again and reappears over time, while the fact check that correct this misinformation won't. So what it tells us is like probably fact checkers need like a better way to ensure that the spread of their fact check continues over a long period of time, because misinformation will. And if we look at the topics, which is quite interesting, so most topics which would be spreading similarly, but if you look at two in particular, which are causes of the virus, right, and conspiracies, those will spread much more over a long period of time and be not as effectively corrected by fact check. And two reasons for that. So causes and conspiracies actually were very, very related topics, because initially people didn't know where the virus come from. There was a lot of talking about engineering, released by a lab, and so on. And conspiracies are very hard to fact check because they're not based on very rational information. So fact checking something that is not rational makes it quite hard to correct. If we look at demographics, so what we observe, for instance, in terms of individual organizations, what we will see is that organizations which share much less, which share most of their misinformation, if they share misinformation in the early periods, and then that's it, while individuals will continue spreading them over a long period of time. And that's somehow expected because the organization will just tweet and that's it, they are done with it, while individuals will maybe find this information or misinformation and share it again over a long period of time. And that means like when you want to deal with that spread of misinformation, you need to focus on individuals rather than organizations. In terms of gender, which it's important to mean that these are automatic models and it has some issues, it's just binary view of that. We don't see actually very clear differences. The only thing we observe is initially, for instance, female will spread more fact checks, but that's it. And if we look now at the impact, so the idea here is that what happened if you simulate a peak of misinformations or a peak of fact check, what will be the response of misinformation or fact check corresponding to that peak? And what we will see is like something nice to see is that if you get a rise, quick rise of misinformations, there will be a quick rise of the fact check that try to address that issue. But over a long period of time, it will stabilize and somehow that's it. So it has an initial impact, but not long term. So again, that's trying to increase the shareability of fact check over time is very important. Now if we observe like the two topics that I mentioned earlier, like various causes and conspiracies, what we can see is like for instance, you will get like fact check will have an impact on misinformation spread, but very short term. And if you look at conspiracy theories, there will be very little impact, which is because conspiracies are a very specific type of misinformation. Okay, so if we try to summarize that, so misinformation spread more than fact checks, and fact checking is actually quite good. I mean, particularly as we went along the pandemic to quickly address misinformation, but the impact was limited in time. So again, trying to keep spreading fact check is very important there. If we look at particular topics, so conspiracies and causes as well are very different, and what we see there is probably they need to be addressed very specifically when we talk about those specific topics. And in terms of demographics, then individuals are the ones to really look for when you try to address the spread of misinformation. Okay, so the last part is to try to basically change somehow the behavior of individuals that share misinformation, which is obviously an extremely hard task. And previously, what has been done mostly there is to have lab experiments, so like more hypotheses, like what happened if we tell you this is fake, will you actually stop sharing it? Those are very hypothetical, so obviously here what we want to know is what we do, what happens if we actually know that person actually shared it and we try to address it. So the approach we use is a bot. And the reason for that is because if you try, so there are a lot of tools, and the website, for instance, I presented, that user could go and check if the misinformation they are about to share is actually misinformation or not. But that needs to go to another website. Those individuals might not know about it. They might also not know to install if there is like a plugin or something like that. So it really reduces the efficiency of those. So what happens if we actually push directly that information? So a key advantage of that approach is they don't need installations of anything. The user will just get it. And also, although we don't analyze the impact there of that particular thing, which is quite important, is even when you correct individuals, that will appear publicly. And then even if that individual might not change their behavior, others involved in that conversation will see that. Which actually can have a bigger reach of the corrective, of correcting individuals. So the approach is quite simple. So we will search individuals that mention misinformations, as how we did for the fact-checking observatory. And then we will use different templates for replying to them, so responding them with the corrective link to the fact-check that corresponds to the misinformation. And the way that we do that is we evaluate different templates and different way of tone and languages. So it can be like welcoming very nicely, or can be quite direct. And we want to see if different languages might be a different way of communicating, might be more efficient to get a positive response for individuals that we target. And the other part as well is to understand what type of user might be more receptive to the bot corrections. So in terms of demographics, again, and other things, like for instance, individuals that that tend to share in the past misinformation a lot, are they more or less sympathetic to the bot, basically, than users that haven't shared much misinformation in the past? So yeah, I was saying, so this work is not done just on COVID data, on COVID fact-check, also with general fact-checking, because know that basically there is not much misinformation around COVID-19 that is fact-check anymore. And we did that over pretty much 2 years, very slowly in purpose, and we kind of created around 4,000 tweets from the bot. And what happened, so we search for individuals that share a particular misinformations, then we will randomly pick a template from the one we have and respond to them. And then we will get their reactions, so based on, for instance, them liking the tweet, blocking us, or responding to us. And then we also get metadata about the user that do that. So again, for instance, how many followers they have, whether they're an organization or not, and so on. And then we get a database that we can use to understand whether the bot is successful or not in reducing, not necessarily reducing the spread of misinformation here, but more having a positive, being positively received by the individual we target. So here are the 7, if I'm correct, 7 templates that we use. So we try to have different ways to communicate. It's quite simple. So basically, we have a factual one to more like alarming or like kind of friendly way of to communicate it, and we want to see how that happens. As you can see, the alarming has much less amount of tweets. It's because it looked initially they didn't like the smiley face so when we try to submit it, so we have less for that, fortunately, data. So how do we classify whether an individual has been positive to the users, to the bot, sending them a message. So what we do, we don't ask them directly, but we check their reactions. So metadata that we can get from Twitter. For instance, we can see, and then we see, like, for instance, some positive reaction. For instance, like if they like, follow us, or retweet, we'll consider that as a positive response to the bot. Negative, it will be blocked. So if they block us, that will be a negative response, obviously. Some other one, like for instance, replying or deleted, cannot be treated very clearly as a positive or negative response. Because, for instance, what happened, for instance, for like icon that spread disinformation, they might, for instance, post their tweets and then later on delete it and repost it again to try to avoid being basically detected. So the delete, not necessarily the best measures. In terms of reply, we actually use it as a negative reaction because most of the reactions when people replied us were negative, so 95%. Okay, so how do users react? Is there any templates or language approach to communicate that is more successful? So what we see in general is very negative receptions to the bot, which is expected. We are actually targeting people that have voluntarily shared misinformations. A lot actually is unknown, so we cannot clearly say whether, you see, like most of the reaction actually are unknown, so we don't know if it's a positive or negative reaction. And then what we can do is we can look at each different type of language. And what we see is that there are no relations between how we communicate to the individuals and how they react. So yeah, so it doesn't matter much the language we use. Most of the time will be negative, the response to it. The other thing we can do is, the idea is that users that have shared a lot of misinformation in the past are likely, we think they are likely to not respond positively to the bot, while people that have done little or they are more positive will be more likely to share, to respond favorably to the bot. We use a tool that's called Misinforme, and what it does is it would give a score basically to an account based on what they've shared in the past and so on. And we can use that information to know if an account has been sharing a lot of misinformation or not in the past. And so what do we observe if we use that as well as demographics, like for instance gender and whether an account is an organization or not. So in general, we don't see much, again, relation. So it doesn't matter whether an individual has been sharing a lot of misinformation in the past or not to have a positive reactions. That's important to note that a lot are actually unknown reactions, so it's also a bit hard to know if some might actually have been positive, right? And the thing that is where there is a difference is in terms of user popularity. So if we, for instance, use the number of followers of users as another information, so for instance, users that have a lot of followers are more popular and have a bigger, let's say, reach on social media, how they react compared to users that have very low amount of followers. And there we see a difference. And particularly between users that have very small number of followers and users that have medium amount of followers. Users that have a low amount of followers will definitely react negatively to the bot, while somehow the medium will react proportionally to the others more favorably. And that's somehow expected because from the literature you will see that well, a lot of accounts are just created to share this information, so they might have a low amount of followers, so they will definitely not react favorably to the bot. And the medium account, which is like more an everyday person, they will maybe more favorable to the bot. And then you have the high one that are a bit less favorable, and that's maybe because they are like more political or things like that, and they actually share a lot of misinformation anyway. Okay, wrong way. So as I said before, so the most reactions to the bot will be negative, and there is no clear relations between the type of templates and language we use to communicate corrective informations. But there are some interesting patterns we observe. So for instance, we will have a lot of, most people will ignore us, which is not displayed here, but sometimes we'll see like people delete and they block us. So they might say, okay, I got caught and I don't want to know more about it. And a few positive reactions as well will tend to be people actually following us and things like that. Now, if we look at actually what people told us, which is an interesting read, and people react to us. So we have kind of a few standard behavior. So anti-bots or people like saying that we work for Big Pharma. Supposedly we get a lot of money from it. That would have been nice. Or they can be anti-bots. We have a few positive ones, so people actually thank us. So even if the impact of the bot might not be as big, we have some successful, very small ones, but some, so which is better than zero, so it has some impact there. In terms of future directions, so obviously like response have been mostly negative, but again, we're actually targeting individuals that have shared voluntary misinformation, so it's a very different types of analysis that usually would be done. So it's expected that most will be negative. But we could see like a difference with accounts that are more popular or less popular. So there, for instance, we could get better, for instance, just target them because those are more likely to share, to approve the bot, basically. And the other things that is important there as well is like, as I said earlier, is like individuals might see that corrections, and even if they are not targeted by the bot. So it might have an impact there as well. And finally, unknown reactions might be actually have an impact. So people might not care about, they've seen what the bot did, and they might change their behavior in future, which is something we need to investigate. And how we could improve the bot. So there is quite a few things. So we could personalize messages based on topics and demographics and users. Adapt to user popularity, so either focus just on those or make messages especially based on the user popularity. And the last part will be, for instance, to create more visual messages because we know they stand out more on social media. And as well, for instance, we could use like large language models, for instance, to generate more natural content. So hopefully we'll be able to continue that bot. So we were approved by Twitter for doing this work, but some people are telling Elon Musk that we should be blocked. So, in terms of future directions of our work, so quite few. So in terms of monitoring, obviously going beyond COVID-19. So now we are more like Russia-Ukraine war, but of course it could be any type of fact checks, as we have database, actually the full database of fact check is more than 140,000 fact checks, so we could actually expand much more the reach of the fact checking observatory. In terms of understanding how fact check and misinformation spread, obviously we can repeat that analysis on the, for instance, in compare between the COVID-19 and Russian invasion, and as well like checking how misinformation spread. And finally, in terms of influencing, so quite a few things. So one would be, for instance, doing some causal analysis to see independently of people reacting positively or negative to the bot, whether they actually change their behavior in terms of how much they spread misinformation after being corrected. So that's something we're investigating as well. And that's it for me. Thank you. Any questions? Yeah.
Okay, I have a question regarding the data. You said that you did the desegregation with gender, but did you have access to other socioeconomic factors like age, geographical location or anything, and try to see at the intersections of those to see who are the really groups that spread more misinformation?
Yeah, so we had access to other, so basically that's because you don't get it directly from Twitter, so it's using machine learning models to extract that information. And we have like age as well, which would be a very good one, but the accuracy is quite low, so that's why we voluntarily discarded that. But obviously age group would be a very good one to get if we had an accurate model to extract it.
Maybe follow up on that. So when you look at the gender, to how you remove all the fake accounts which were created just to spread the information using not real data, even those who have already good history and they are used, for example, for hybrid operations? So we don't remove those. Well, there might be some fake ones, obviously there. There's definitely some fake ones. Yeah, we don't. We just use what the machine learning model extract from them. We know that they are accurate in principle for extracting them, but obviously if there is a legitimate account, it doesn't work very well. Another thing that there is limitations in those models as well is, for instance, at the beginning, we didn't do that analysis because we know it's not very accurate. For instance, like the map I showed at the beginning, so it's automatically extracting locations. For instance, there will be some users that will say they are on the moon or things like that. So those wouldn't work. So it's kind of the same here. It wouldn't work in some cases, but the idea is like in numbers, there would be more it's accurate ones.
Because COVID is one thing, but at least here in Poland, we have very much and very quickly transited from the COVID situation to, well, having war very close to our own borders. So back early last year, Poland was under massive influence of fake news from Russia. And I was talking to one of the guys from the government, from the internet security side. He was saying that sometimes up to 30 to 40% of the posts are coming from certain IP addresses in Russia, and notably from the troll factory in St. Petersburg. So, well, I mean, I find it very useful not only for the concept of the, I mean, for the situation of the pandemics, but also for the, this kind of hybrid warfare and so on. But the question: are you looking into blocking or identifying certain IP addresses if somebody is so sloppy to keep them open, so that mark it as you guys are posting this from the location which is associated with misinformation or something like this?
Yeah, unfortunately, we don't have access to that information, so we can't. So the only thing we can see is the accounts themselves. So obviously, we can analyze like those accounts if they share a lot of misinformation or not, and the bot could actually send messages to them. Yeah.
And if over time, maybe later on, a fact can be untrue, or the other way around. So how do you deal with the things that are unknown in relation to what we find?
Yeah, that's a good question. Yeah, so we don't necessarily or recorrect for that. The database is updated for that, but for instance, because for the FCO, all we generate the reports is as the time of the information. So at that time, that would be correct, but then it might change over time, obviously. The thing we observe as well, for instance, so the study that was presented at the beginning, for instance, and that we did until 2021, So we could see like the one that were very different in terms of behavior were like the conspiracies and causes. And when we redid a bit that study to check if it changed, we could see that now it would be more, for instance, vaccines. So the one that we were appearing were the vaccines because they didn't exist initially. So it was more about the causes and things like that, the biggest misinformation, and as it moves, then the way people share, it will depend on the situation as well. And now we see, mostly authorities and viruses that are the ones that are most focused on the misinformation part, and conspiracy still. Yeah, no more questions? Okay. Thank you.
All right, I guess it's time to restart. Welcome back after lunchtime. My name is Kees Boersma. I had the privilege to sort of lead the work package on governance. And it were difficult times, of course, but in a way I also had a sort of an easy job because there was so much creativity in our team in the work package 1. We went through rather unexpected times, and that is true for how the pandemic evolved, but also for the choices we made in this work package. So what I will do is, in 10 to 15 minutes or so, I will sort of set the scene of what we have been doing in the work package in terms of studying, understanding governance, providing recommendations on the fly, and also harvesting lessons learned of the cases that we have sort of designed and undertaken during the last 2.5, 3 years. And it was rather unexpected, so it was quite a journey, but with some interesting outcomes that we will show in the coming hour and a half. But also after the sessions are over, there will be a documentary showed as one of the sort of outcomes, deliverables of this work package. So again, I will sort of set the scene, but then after my talk, the most interesting part, the case studies that we came up with in the work package 1 will be explained. So there will be a case study presented by Cato Janssen, one of the researchers at the Vrije University in Amsterdam. In particular, how nursing homes or people in the nursing homes actually try to cope with the consequences of the lockdown. The exhibition or the documentary after this session is about the same kind of questions, but then on schools. And that documentary will be introduced by Lianne Cremers. She's the postdoc at the VU in Amsterdam. And also the question there is, how did school children, teachers of secondary schools actually cope with the consequences of the lockdown? As we deem them, those organizations, very important also in terms of governance, and that is something that I will explain also in a minute. Then we have, I think in the sequence of the order, I don't know, Yiannis, I think, will talk about procurement and the global supply chain. Because that's also a governance issue. So we have been collaborating, of course, with HANKEN, with Gyöngyi's group on that, showing also that, hey, we are willing really to learn from each other across the work packages also in the HERoS project. And Wojciech, he will talk on behalf of the PCPM on guidelines, also in discussion in relation to the guidelines by the WHO. And then also last but not least, of course, Agnese Rollo from the Italian Red Cross. She will talk about the activities that the Red Cross also performed during the lockdowns in Rome. Being involved with volunteers, spontaneous volunteers, in relation to supporting the most vulnerable during the pandemic. All right, talking about governance. So the first deliverable, honestly, was recommendations for governance and policies. And that was planned, the sort of the milestone, the deadline, so to say, was 6 months after we started the research in HERoS. And that is sort of, for me, that was a sort of, I don't know, wake-up call of some sort, that we, designing the work package, also had our assumptions before the pandemic started, because as a reminder, so we started HERoS in May 2020. We designed the whole HERoS project and also the work package somewhere in February 2020. And I had the idea, hey, after 6 months, the pandemic might be over, and then it's time to move on to the lessons learned. Well, this was, of course, the first assumption that was being broken. Yet we came up with recommendations for governance and policies, sort of on the fly and not foreseen. And on the fly means that we started to work together with responding organizations in particular in the Netherlands, as far as the measures like the lockdown allowed us to do. So I will elaborate a bit on that. The second deliverable in this work package was actually deliverable 1.3. Interestingly, and that were the guidelines designed and provided by the PCPM. And then the deliverable 1.2, they were about the lessons learned and best practices. And they turned out to be a sort of an incentive for us to be creative and move beyond looking at the, let's say, mere recommendations for formal authorities, but also look for societal actors and how can we not just recognize their actions in terms of governance, but also how can we actually work with them in developing lessons learned that can hopefully also be picked up in the future, working towards what we started to call a resilient way of responding to crisis, and also a resilient way to organize vulnerable organizations and groups. All right, so that is already in a sort of an introduction. So here in a nutshell is what we were about to do in 2020, already 3 years ago. So governance is about many things. It's about decision making, but for us it was very important to also look into processes of coordination and collaboration, because there are, as it could have been foreseen, many actors becoming active in response to the pandemic. And the question is, how can there be a sort of a collective understanding, a collective sense-making, I will come back to that in a minute, of what is going on in that devastating time, but also are there ways to align the actions of the otherwise quite isolated parties? And that really is a governance issue that proved to be rather difficult, with local problems and issues all over the globe, virtually, but also with many local initiatives and local solutions that may work in one place, but are hard to translate or scale up to other places. So in the first phase, what we did is, hey, trying to understand what it means to govern a crisis like COVID-19 pandemic. There's quite some literature in the field of governance, also in the field of crisis and disaster governance. So we actually try to harvest already what was out there, but also in discussion with both scholars and practitioners, we try to understand how we can, take the best out of that, what was already known in terms of crisis governance, but then translate that to actually what we were living through, namely the pandemic. And that in itself was quite a challenge. So we tried to identify the bottlenecks, the frictions of choices, and how to overcome. And then again, in the second phase of the work package, we try to work towards sort of the lessons learned. Well, and there were many, and they are ongoing, as I have to say. Now, in virtually any country that has been affected by the pandemic, but let me talk about the Netherlands. There will be a parliamentary investigating committee going on and established, and an ongoing sort of reflection upon what happened. And the pitfall of these kind of investigation committees is that they are starting to shapecoat people in formal positions of authority. So when I criticize, or when we criticize top-down governance, when we start to criticize also people in positions of formal authority, in formal response organizations, that is only to reflect upon what happened and to also take lessons learned, rather than starting a blame game. Because if we shouldn't do anything, it is starting a blame game instead of taking the lessons learned seriously. So I don't know about you, but when I sort of started to experience the COVID-19 pandemic and its consequences of the measures, in particular the lockdown, I really started to make sense of what are we living through? What is the kind of crisis that we are reflecting upon, that we are living through? And in the literature, there is a sort of a distinction between a sudden onset crisis, like floods, like a fire, and so forth, and a creeping, long-lasting crisis. And the pandemic has been sort of positioned in the literature in this way, and it's helpful because then you can also relate back to the literature on slow burning and creeping crisis, and we are undergoing quite a bit. So also climate change related crisis can be considered as such, and a pandemic surely as well. So it has a long incubation time. The causes are quite often outside of the area where the crisis is hitting, and it will remain over a long period of time. But there are certain moments in that creeping crisis that sort of look like a sudden onset crisis. And this all means that it is quite difficult to deal with. Of course, for us, citizens, for members in organizations of all sorts, but also for formal authorities and for those in positions of decision-making. It is then labeled as a wicked crisis, or the president of the WHO, I think, said, hey, there is no silver bullet, right? So we are trying to make the best out of it, but there is no one way to deal with the crisis situation. So here we are, we have to design sort of a framework for governance in our work package, and actually we are quite often guessing in the dark what to do. I think it was our Prime Minister who said, hey, we have to take 100% of the decisions by 50% of the knowledge about the virus, right? And that sort of paradox is what we are actually were facing. So it's a wicked problem in that sense. So crises are, in this way of reasoning, a collapse of sense-making. So we take things for granted in the way we organize our healthcare system, in the way we actually go to school, go to shopping malls, and so forth and so on. But during a crisis that hit virtually all aspects and all pockets of society, we are going through what Carl Weick, one of my favorite scholars in the field of organization sciences, labeled a cosmology episode. So the world is upside down, you don't know how to act, what is going on, what is the next step to be taken? There are tons of uncertainties. So that means also that when we look at actions, also of decision-making, also of coordination, also of collaboration, there is action ambiguity. So we think we are taking the next step in a certain direction with intended outcomes, but hey, there can be unintended outcomes. Or the pandemic is evolving in such a way that you have to step back and take another action. So there's a lot of ambiguity. So what we were interested also in this work package, a little bit I have to say in hindsight, but still on the fly, we realized that, hey, actually what we are trying to do is understanding how not only formal authorities, but basically society at large is trying to restore the loss of sense-making. And it can be done in different ways. I won't go into detail, but by creating situation awareness, by trying to understand the complexity of the matter, and also, let's say, be creative and improvise a lot, and then also try to come in a mode, in a state of reflexive learning. So restoring the loss of sense-making for us basically was the main part of the crisis governance. All right, so some results or the things that we have been addressing over the last 3 years or so, and the work is ongoing. Also after HERoS is over, because hey, WHO might have declared an end to the pandemic, but doesn't mean that the virus is away, or that people aren't suffering from the consequences of both the pandemic in terms of long COVID, but also the consequences of the measures. So mental health, for example, is very important to keep on the attention to. So we were basically interested in this sort of context to understanding coordinating principles, but also trying to understand the loss of sense-making, the restoring of sense-making, towards, ideally, a shared understanding of the crisis and the consequences of the measures. All right, I have to go to another direction. Here you go. Well, there are pre-given sort of principles of what is considered to be good governance in times of crisis and also in times of pandemics. So this is taken from the guidelines of the WHO. I think, Yiannis, you came with that idea, hey, let's look at what is there already provided by the World Health Organization in terms of what is considered to be a good way of governing a crisis. So we have to pay attention to transparency, to accountability, to participation, integrity and capacity. All those are sort of predefined. And I won't say they are all out of the window in a pandemic situation such as COVID that has such a huge impact on, again, virtually all pockets of society. But at the same time, we really missed the variety of actors that are becoming active, foreseen and unforeseen. Foreseen in terms of, hey, there are formal authorities, there are formal response organizations, there's the NGO sector, there's the Red Cross, but also unforeseen or emergent, so from bottom up. So what is the grassroots doing? What are citizen initiatives? How do they look like? Can they be part of the governance mechanism and part of the sort of restoring of the sense-making that is so much needed? So we were missing out sort of society and sort of missing the different modes of decision-making. I recognize so much of the talks provided before the break, but I don't know who said it, but hey, but virtually all were involved in the decision-making processes. So what do you do? Will you send your children to school the next day or not? That's also part of the decision-making processes during the pandemic. So we were interested not just in decision-making of the formal authorities, but then also in the, let's say, the dispersed way of how decisions were being made during the pandemic. And here's a sort of a perfect example of it. So based on this, in the Netherlands, but I bet also in your country or in other countries, there are formal procedures how to deal with the pandemic. So the pandemic as such was not an unknown thing in the Netherlands. it has been so the response to a pandemic has been made explicit in formal procedures and guidelines. I remember in 2017 I was involved in a large exercise in the Netherlands, which was about an outbreak of a pandemic. And then during the exercise that lasted a whole week, the whole response organization, formal authority, were upscaled to the level that actually we witnessed during the pandemic. So it's all there. But at the same time, I took this picture in an operational response unit of the safety regions in the Netherlands, who are playing an important role in responding to the pandemic. And here, actually, what you see here is a sense-making process going on. On the fly, the formal responders were trying to make sense, first of all, who is involved in the decision-making processes, who is doing what, how do they interact with one another, aren't we missing out someone, and so forth and so on. So this is a sense-making process of the various organizations that are involved in responding to an organization, but also how they try to coordinate their actions and how they interact with one another. So then we went back, knowing all this, we went back to the literature, and I won't go into detail about governance because you can crazy about it and talk about the whole day about governance, but basically we looked into the main paradigms in governance, in particular in crisis governance. And so we found actually three bodies of literature that were a helping hand for us to make sense of that crisis situation, but also about decision-making processes. So it's multi-level governance, network governance, and participatory crisis governance. And in particular, the last one was for us really important to understand, to go beyond decision-making of formal authorities, but also pay attention to societal actors, foreseen and unforeseen. So foreseen like the civil society, foreseen like Red Cross, working with volunteers, but also unforeseen. So spontaneous volunteers, citizens mobilizing themselves in concrete actions in response to the crisis situation. So Agnese also in her talk will address an example. So this is really for us an important framing of the governance in terms of decision making, in terms of coordination, and in terms of collaboration, to shape a sort of a coherent, I won't say encompassing, I mean there are always things, also blind spots in what we are doing, but at least we are trying to create a framework in which through which we can understand what we call the whole of society approach to the crisis, because we also think that is very much needed. So not just having an eye on the formal authorities or the, let's say, professional response organizations, however important they are, of course, but also recognizing the actions and interactions of the grassroots, of bottom-up organizations, of spontaneous volunteers and what have you. And sort of, I will not go into detail necessarily of all the information in this table, but in the columns you see the different actor groups, if you will, so the states and the institutions, so those are the formal authorities. Then networks of organizations be established to respond to a crisis. Can be the fire service, can be healthcare organizations, and so forth and so on. But also organizations like schools, churches, mosques, religious organizations, soccer clubs even, who have members and who work on a daily basis with citizens, inhabitants like you and me. They also became active in responding to the crisis, at least also in co-organizing lockdowns, but also trying to cope, again, with the consequences of the measures, such as the lockdowns. So that is what we label networks of organizations, a perfect fit to the insights from the literature on network governance. And then eventually the resilience or the participatory sort of lens that we adopted again, to understand the grassroots, to understand how ordinary citizens and inhabitants try to mobilize themselves, pool resources together, and also started to respond to the crisis situations, but rather in unexpected way. So potentially there is a clash between how formal organizations and authorities operate based on their standard operational procedures that are predefined, that are being trained, and so forth and so on, and the unforeseen emergent actions of the citizens, of the grassroots, of volunteers. And there are ways to bring them together, but as you can imagine, that is quite a challenge. But hey, that's the governance issues. That's the governance issue that we are talking about. So tons of dilemmas and potential tensions to overcome, which we try to understand with the metaphor of translation. So there have been implemented all kind of guidelines. There were provided all kind of information dashboards, as we have also seen before the break. All kind of data sets also provided via communication to the public. But then again, those guidelines developed at the central level, national level, or even global level by the WHO, they have to be interpreted and translated to a local level into new work routines, into new organizational routines, into ways of acting of individual citizens. And that is quite a challenge that we have seen. And that then is also part of the coping mechanisms that Cato and Lianne will show, in particular zooming in nursing homes and schools. Why? Because there are also, you know, they appear to be, they are also the most vulnerable in relation to the measures taken. So we were interested in that translation process between the different actor groups that we defined in the governance framework. And there were tons of examples. I can only show this picture because I'm about to give the floor to my colleagues to present the cases, but this is an initiative in the Netherlands from a social entrepreneur who started to produce domestically mouth and face masks together with her employees in the company that she established 5-6 years ago, together with refugees in the Netherlands, or eventually they became status holders. So they were entering the labor market, but there are many thresholds to enter the labor market in the Netherlands as a status holder for various reasons. So she started a social enterprise working with status holders, and during the first lockdown, where there was a shortage of face and mouth masks, she started to produce PPEs in a small scale, but still very importantly, in collaboration with the Ministry of Public Health. And that production line is active as we speak today. So it's an example of an unexpected action of an organization, a social enterprise in the Netherlands in response to the crisis. This was not foreseen. It's in no standard operational procedure. It is a very important part of what we label the whole of society approach to the crisis management, to the crisis situation that is very much needed. A very interesting initiative. We published also an article about it, so if you want to know more detail, of course we can share. And this is then the example of citizen groups, spontaneous volunteers starting to provide free meal in their own neighborhoods. At the left-hand side, you see a picture from Rome, shortly Agnese will tell that story. At the right-hand side, you see a picture close to where I live, in a neighborhood in Amsterdam. And the key thing here is that it recognizes not only the actions of citizens in response to a crisis, because what they are doing is they started to provide free meals to those who are suffering from the lockdown and who are isolated, for example, elderly people who couldn't go to the supermarket anymore, but also people who have what we call a low social capital, so they don't know many people in their neighborhood. So they are vulnerable because they are becoming isolated. And providing them free meals by their own neighbors was for them a way to survive. So here you see, again, a grassroots initiative that became part of the response to the COVID-19, in particular during the first lockdown. And what we did, through the HERoS activities, we actually started to engage with them, setting up what we called a virtual living lab. And in the living lab, so we actually took the neighborhood as a living laboratory, so to say. What we did is we organized a series of virtual meetings, online meetings, between the various stakeholders that are sort of co-responsible for providing meals to vulnerable people. So we are talking about the food bank, we are talking about the municipality, we are talking about the Red Cross, but then we are also talking about those informal citizen groups. And we had a series of online meetings in which we try to understand collectively what is going on. So where are indeed the most vulnerable people? Don't we miss out for people that don't have that network or that are not recognized by one of those groups? We are try to break down the silos of the otherwise isolated organizations responding to the crisis to support vulnerable people. And in fact, what we are doing, we are trying to create new networks and new dynamics between the responding organizations. And over time, we noticed that there were more and more sort of exchange of information between those indeed otherwise isolated groups. There was exchange of information. There were new routines coming up. And this is sort of a latent network that after the urgent need of providing free meals to vulnerable people in the neighborhood are still active today, but now in response to Ukrainian refugees coming to the neighborhood and also looking for ways to integrate in the local life world of those living in those neighborhoods. So it's very much a sort of a latent network that you know will become active, but you don't know how and when and with what kind of resources. But better know the social fabric in your city, so to say, from the point of view of the formal authorities, and better start working and collaborating rather than imposing forms of accountability, forms of legitimation that typically belong to the world of formal authorities, but rather start to collaborate and work together. So that was one very important lessons learned out of this case study, so to say. So lessons learned, again, make sense of what is going on in times of uncertainty, do that collectively, create feelings of ownership. Most of all, if you start to collaborate, if you start to coordinate, do it on the basis of trustful relationships and trustful I know that in the agent-based modeling, one thing that comes into the equation is trust. And that is, of course, key in any interaction, but in particular in times of crisis, in which there is a heavy pressure on people, on organizations, on the well-being. That is very important. But there are tons of lessons learned, of course, right? So I'm not cherry-picking, but those are the lessons learned that belong to our line of research that we undertook in Work Package 1, but there are tons of more lessons to be learned, of course. And also recommendations, I will not go to the whole list, but one thing that I sort of have the urge to say is that, and this is a sort of an outcry to formal authorities, WHO, but also in the Netherlands to RIVM, include more science disciplines than you have been done before, because the outbreak management team in the Netherlands that consists solely of experts from medical sciences, epidemiologists, and they were of course very important. But in the recommendations for the next step to be taken in response to the pandemic, the recommendations to the policymakers in the Netherlands, what was really missing out is behavioral scientists. What was missing out is anthropologists trying to understand local cultures and so forth and so on. So as one of the lessons learned and recommendations for us in discussion with the authorities in the Netherlands, this is definitely one thing that we brought to the fore. All right, so I think I'm sort of there. Now there is 4 case studies to present, but here's the formal, let's say, deliverable 1.3. That was about changing the workflows and methods by PCPM. Wojciech in a minute will explain details, but this is taken from the deliverable, what PCPM have been doing, a really, really, really good job. And also the lessons learned and best practices, which will be presented then by Cato and by Lianne. A rather creative way of understanding how organizations with vulnerable people try to cope with the difficult situation. And then, that is the end of my talk. And then we have, and then I guess there will be a continuation of the slidecast. And I think the first to present then is Cato on nursing homes.
Okay. You are much taller than I am, Kees. So let me see how this works. And I think this is not my presentation. Okay, perfect. I can't get this lower, but I can I think like this is fine as well, right? Okay, perfect. Yeah, so Kees just introduced our work package, and it's my honor to then introduce the first case study. And like Kees said already, we conducted research in both nursing homes and secondary schools. Thank you. Now I don't have to stand on my tiptoes. And I would like to start by presenting our case study in Dutch nursing homes. And let me see. And first, a small introduction on the situation in nursing homes, specifically in the Netherlands. And for some of you, this might be recognizable for your own country as well. But basically, in the Netherlands, 50% of COVID-19 related deaths in the first 6 months of the pandemic were in nursing homes or long-term care facilities. And this was further amplified by the fact that in the Netherlands, the nursing home sector was very overburdened even before COVID. There were a lot of staff shortages and budget cuts. And then when the pandemic started in the Netherlands, there was a lack of personal protective equipment, specifically mouth masks. And that meant that nursing homes were not well equipped with this protective gear because the focus in the Netherlands at the beginning of the pandemic was very much on hospitals. And we also saw that nursing homes were kind of disregarded in the sense that there was a focus on hospitals, but also when there was a focus on nursing homes, they were very much compared to hospitals. But I will also elaborate on that a bit further. So then what we did is we went to a Dutch nursing home and with the idea that we wanted to look at organizational trauma, which is defined as a process in which external factors inflict harm onto organizational members. And what's interesting about organizational trauma is that it's both kind of a compilation of traumas of people in the organization, but because they are experiencing this all together, you can also see that the organization itself becomes hurt or wounded. And then the process of kind of moving on from this organizational trauma is what can be called organizational healing. And that's really where we focused our paper on as well, because we wanted to look at how this organizational trauma manifested in Dutch nursing homes, but also what the process of healing looks like for a crisis of the extent that we saw in the COVID-19 crisis. So there's two important factors in organizational healing that I would like to introduce you to before I show you some of our case studies and the things we found, because I think you could be able to recognize these elements yourself as well in what I will show you in a minute. And these elements are collectivity and leadership. And first, for collectivity, it's important that there's a lot of empathy amongst organizational members, and this is also shared through the act of collective story sharing. But that all cannot happen if there's not a leader who allows the organization to open up to these practices of healing and these practices of collectivity. So then very briefly about the methods of our case study. Kees already said that we use quite some creative methods. So we did participatory action research, which meant that we didn't only come up with the research ourselves, but actually the respondents in the field helped us to find the focus of our research. So it was the director of the nursing home in which we conducted our case study that suggested that we focus on trauma. And then we did visual ethnography, which meant that we brought our camera into the field. And also when I will be presenting some of our results, I will do so by showing you short clips. And in the end, that will all be kind of like put together into an ethnographic film. It's not the one you're going to see this afternoon. That one is on the school case studies. But also for the nursing homes, we're still developing an ethnographic film. And then the results. So after going to the nursing home, and we spent quite a bit of time there, both with and without our camera, and we really got to know the people there. And when we wanted to assess their trauma and their experience in the COVID-19 pandemic, we felt that there were 4 main ways in which we could summarize their experience. And that's the 4 you see here, obviously. And the first is that there were a lot of emotional challenges when working in a nursing home during the COVID-19 pandemic. And luckily we filmed, so I don't have to explain to you what this means, because I will let one of our respondents do so. And I hope the sound works. I don't know if can I click play or...
Ik ga dood misschien, dacht ik. Nee, ja. En opeens was ik aan het huilen. Mensen belden mij, mensen stuurden me berichtjes en zo. Dat maakt ook heel kwetsbaar, want oké, ze zijn er wel. Weet je wel, dus... en opeens begonnen de tranen en 2 dagen was ik er zo. Ik kon niet stoppen met huilen. Ja. Ja, dat heb ik ook nog nooit meegemaakt hoor. Dus ja. Ja, heel heftige periode, ja.
Okay. So what you can see here is that nursing home staff, they were challenged to kind of experience their own emotion alongside having to experience the emotions of residents as well. And besides what the nurse you just saw said, we also heard stories about how hard it was to see residents declining and how it was so difficult to navigate all these different kind of emotions within the nursing home. And that's kind of like moves us into the next result we found, which is cultural incompatibility of infection control strategies. I already said in the beginning that there was a lot of focus on hospitals, and nursing homes were also really challenged to adapt more of a hospital approach, but that meant that they had to let go of their notions of good care, which put a lot of stress on nursing home staff. And I'll again show you a short clip of one of our respondents.
Ik heb op een goed moment een appje gestuurd. Ik heb hem op mijn telefoon. Moet ik hem voorlezen? De ingerichte COVID-unit was één grote, sorry voor het woord, klerenzooi. Toen ik er maandagochtend een kijkje nam. Afval en waszakken over de grond, slingerend verspreid. Roepende bewoners hangend in bed. En matrassen tegen de muur opgestapeld. Lege rolstoelen op een hoop en gordijnen bij elkaar gehouden met knijpers. Het huilen stond me nader dan het lachen. En dat alles onder mijn verantwoording. Mijn God, dit is niet vol te houden.
So what we saw here is that the nursing home had to really adapt this sudden infection prevention, quite rigorous strategy. And that meant that they had to put residents into this makeshift COVID unit. And as she described, this was not a very good solution, which also meant that later on they had to transfer residents to other facilities that had better COVID units, which was also particularly challenging for the nursing home staff, because when the residents joined their nursing home, they made a promise that they could stay there for the rest of their lives, and now having to transfer them somewhere else, specifically when they were sick, was very challenging for the nursing home staff. And so that's also why we found a third team, which was really about the ethics of decision making and how to navigate all these decisions that nursing home staff were challenged to make, because the protocols in the Netherlands, they still made room for difficult decisions that staff members had to make. And I want to show you a clip in which someone explains this as well, and I would just like to say that this one is particularly heavy as well, so just so you know before watching it.
En een van mijn medewerkers gaf leiding aan afdeling Arbo. En die moest echt kreeg honderden telefoontjes van doodsbange verzorgenden per dag. En die moest tegen die mensen zeggen, want dat was toen het beleid van het RIVM, van nee, je moet ook hoestend en proestend naar je werk komen. Je moet doorwerken totdat je koorts hebt. Je mag geen test doen, want we hebben te weinig testen. Niks aan de hand, doorlopen en werken. Ik voelde me heel erg verantwoordelijk voor dat beleid. Het was gewoon echt fout beleid. En op een gegeven moment ging er ook iemand dood. En dat is dus zeg maar mijn trauma. Dat ik toen niet gezegd heb van luister eens, dit is onzin, dit beleid verkopen wij niet. En dat ik haar niet heb kunnen beschermen tegen het gevoel dat die hele afdeling nu heeft. Dat ze gewoon mensen de dood in hebben gestuurd, want dat deden ze.
Yeah, so I think this clip really shows how much pressure was put on nursing home staff, which not surprisingly left quite some scars on the organization and on the people there. So the last thing that we wanted to do is also to look at the future a bit and look at what perspective for organizational healing are there. And so I have a last clip.
Maar ook dat, je merkt gewoon dat mensen nog niet helemaal hersteld zijn. Net wat kortere lontjes, net wat sneller defensief. En over het algemeen gaat het wel. Maar als dan de volgende COVID-uitbraak komt, ja, dan zie je ineens dat er toch nog wel littekens zitten. Iemand overleed hier in huis aan ouderdomskwalen. Maar alle trauma's van COVID kwamen terug bij de verzorging die erbij stond. Weer iemand die overlijdt, ja. Het is een verpleeghuis. Dus, maar dat maakt het verdriet niet minder.
So as you can see from all 4 of these clips, we found, we had quite some heavy conversations, and we found very confronting stuff about what happened in nursing homes, but specifically what happened to nursing home staff. So what we wanted to do with our work is look at the theory on organizational healing and kind of put this in perspective of how we can also help the nursing home sector to heal from this trauma that they suffered during the COVID-19 crisis. And I will share a bit about the theory on organizational healing, which basically says that there's 3 stages. Of the first of being the inflammation state, where there's a focus on immediate care of those most vulnerable and a supply of resources. And there was really the period in the beginning of the pandemic where nursing homes were also challenged to adapt to this hospital-like focus in order to provide this immediate care. The second stage is the proliferation stage, in which there is a collective sharing of the burden of trauma. And this is when people connect emotionally. And then in the remodeling stage, the idea is that you let go of formal organizational structures and kind of come to a ritualistic end of the crisis. However, what we found is that with the COVID-19 crisis, Kees explained earlier that we can see this as a slow-burning crisis rather than a fast onset. And these last 2 stages are harder to conceptualize when we're talking about a slow-burning crisis, because you're constantly reliving the 3 stages, and it's hard to kind of make out when there is an end to the crisis. So you could actually say that the nursing home sector is still in the remodeling phase and looking for ways to kind of get this trauma out there. And we are aiming with our film and with our research to help with this, as we're hoping that by kind of reopening the wounds, by revisiting this trauma, we can collaboratively experience these emotions and therefore kind of collaborate in moving to this ritualistic end as well. However, to do so, it's mostly important that there's more research done as well on how you can really translate organizational healing to this slow-burning crisis and how you can help the sector to reach the remodeling phase. But also there needs to be more attention to the experiences of nursing home employees specifically, because as you saw, they had such a hard time, and I think it's not addressed enough in order to help them as well to move on. So what we also did to kind of like get more of their experiences out there is we collaborated with an artist who made very touching and impressive drawings of some of the quotes of our respondents, and they're collectively put into this little booklet. So you'll have an artwork and then a quote next to it, and there's still quite some of them out there on the table. So if you want to know more about the experiences of nursing home staff, you can do so through here. And we also published the research that I presented in an article, which also is at the table. And like I said, we're still making the ethnographic film. But Kees just told you also about the blaming that's going on in terms of the COVID-19 crisis. And the nursing home sector is definitely being blamed for what happened there. So it's quite a sensitive subject, and we're hoping that by publishing our ethnographic film in the right way, we can also help address this issue. Yeah, that was it. Thank you. And then I think I can give the floor to Yiannis to present the next case study. And you probably need the mic a bit more up again.
I think it's okay. Okay, thanks very much. So this is going to be another presentation of a case study, which is like a shorter, it's not an empirically driven work, and so fascinating with amazing clips that you saw that Cato elegantly presented. Thank you very much. That's great. So this is going to be, we thought, let's make a small side project and work together the two work packages. We have work package 1 and work package 3 here collaborating, and you see the names of the researchers. We tried to focus on cross-border governance. And we tried to look at two initiatives that happened, that cross-border governance and the collaboration happened in the joint procurement, the EU joint procurement of COVID-19 vaccines, and also the COVAX initiative for the purchase and distribution of COVID-19 vaccines. So we have these two examples that we have to reflect on what were the governance structures and how they worked, what worked well and what were some of the challenges, and what does it tell us in terms of governance structures. Right, as I said, so you see the objectives of work package 1, which is led by the Vrije University in Amsterdam, and the work package 3, led by HANKEN. So we're trying to connect the crisis governance focus with a focus on the management of medical supply chains and preparedness and response to emergency situations. So in terms of cross-country collaborative procurement in public health emergencies, there is very sound reasoning for increased collaboration in such situations. There are clear benefits, so we can reduce pandemic-induced behaviors such as panic buying or speculative pricing. It helps avoid price wars, reduces the time spent on procurement, reduces related transaction costs. So there are clear benefits, and you can see the value of doing that. Nevertheless, in practice, that's not easy. So it requires a lot of time, and the most important element, it requires an element of trust and some structuring of working practices. And this is for organizations or agencies that do not interact on a regular basis, that can be very problematic. There are some examples in the bibliography as well about how that kind of larger scale governance interaction might happen. And in some cases, there might be a central agent, so it's a center-out hierarchical coordinating center that coordinates all these activities, or it might happen in a more kind of bottom-up or peer-to-peer horizontal network that this network established in a more organic and dispersed way. But the complexity of cross-border collaboration renders this kind of the more formal, traditional center that coordinates and aligns all the activities, makes it very hard. So there needs to be kind of a combination with more innovative, decentralized arrangements that need to be put in place. And here we try to, these are the questions that we try to reflect upon in our desk review. So we try to look at the two initiatives, the EU's joint procurement and the COVAX facility. And these are cross-border initiatives. They differ in the scale, in the geographic span, in the policies or the organizational structures that are in place. But also they have similarities. They are cross-border, and very importantly, they are value-driven. They're inspired by a principle of solidarity, for example. But they stemmed out of necessity in the situation that we had to face. And then we looked across the two initiatives in terms of what were innovative governing structures that they had to be created for this collaboration to happen. What resources and funds were committed to these initiatives, and how and where decisions were made. What were the forums, or how that collective decision making was structured. And looking at the first initiative, the European Union Joint Procurement, first of all, it was a very challenging. Looking at the first question that we said about the innovative policies and governance institutions, the joint procurement in that particular area of public health is problematic because legally, the Treaty on the Function of the European Union delegates all the authority about health issues to the member states. It's not a domain of competence at the EU level. So there are legal impediments to coordinate and delegate authority and action at that level. Nevertheless, there was a precedence that happened and was very helpful. And that was the Joint Procurement Agreement that emerged in 2014, and that was in response to the H1N1 influenza pandemic. And that created a critical infrastructure where, for the first time, voluntarily, the governments and the different institutions in the EU, they came together, and the member states voluntarily delegated some of that responsibility on a public health emergency to this central level. With the onset of the pandemic in early 2020, around March 2020, the EU Coordinated Crisis Response Initiative, the Team Europe, was formed, and with the aim to combine the EU resources. That was the member states, the European Commission, and the financial institutions, the European Investment Bank and the European Bank for Reconstruction and Development. So we had a team that came together and combined EU resources. We had also, for the first time, the Rescue EU stockpile of medicinal equipment in March 2020, more or less around the same time, which was adopted under the EU Civil Protection Mechanism. And this now, more recently, in September 2021, has become a formal bureaucratic unit, which is now Directorate General, which is the HERA Directorate General, that is functional since the beginning of this year, of 2022. So we have now a formal bureaucratic infrastructure that has been built and over time by building on this experience. Another very important element here, another innovative policy that was adopted was in June 2020. It was a European strategy to accelerate the development, manufacturing, and deployment of vaccines for the COVID-19 with a double aim to improve efficiency and effectiveness and also increase solidarity, especially among the poorest and smaller countries in the EU. And the Advanced Purchase Agreement was negotiated by the joint negotiation team to offer upfront financing for COVID-19 vaccines, and there were almost 3 billion invested in that particular industry. So we have interesting, innovative policies, innovative institutions, and innovative financing mechanisms that they came together to help achieve cross-border collaborative governance. And this is when we talk about resources that were invested. So during the period August 2020 to November 2021, the Commission signed 11 contracts with 8 vaccine manufacturers. You see here the manufacturers, and at the bottom there you see that there were 4.625 billion vaccine doses in total to a cost of about 71 billion. So quite a substantial achievement, although the EU was a bit slower by about a couple of months compared to the United States or the United Kingdom in the very early stages of the pandemic response. And then if we reflect on some of the challenges from the COVID-19 pandemic at the EU and the joint initiative. So the EU, as I mentioned before, is not vested with sufficient legislative power, and that is very, very crucial. Also, it suffers from fragmentation of authority and institutional complexity. There are many political decision-making layers and a lot of bureaucracy in the EU, and that makes things not become speedily adopted when needed, especially in crisis situation. There's also, in this already bureaucratic and slow-moving organization, the best that the EU is, we needed additional layers of coordination, the additional initiatives and the structures that I mentioned in the previous slides, and that complicated further the situation. And also, as I mentioned before, healthcare, it lies at the national level. So this is a national priority. In a crisis situation, the government and the institutions, in a particular country, they will prioritize their own country needs rather than putting solidarity with others as a secondary priority. And there is no unified legislation about pharmaceutics and medical devices, so that integration level doesn't happen. That's a great challenge. And in terms of the Advanced Purchase Agreement that the EU initiated, there was lack of integration of the national innovation policies. So all these policies were developed by different countries in order to be competitive, to attract more of this investment by pharmaceutical companies. So it was very difficult to coordinate and avoid conflict. And there was insufficient information sharing. A lot of that data was classified by many member states as classified data, and they were not keen to share it with the rest of the EU member states. And that created a lack of trust, which, as Kees mentioned before, is a crucial element in collaboration. And there were parallel agreements with other companies, for example, Hungary with Russia getting their vaccine. And there were disputes between member states and pharmaceutical companies like AstraZeneca and the story there. So the benefits, you can see that there was facilitated information sharing, there was standardized preparedness guidelines, but very importantly, we started now working on standardized training and creates a common value system, but also a common knowledge base on that. And it's a linear approach now with the new institutions that we have and the new rules. We created more through interaction and regular exchanges. We created common rules, common practices, a common operating system, and that creates a more linear approach to governing. And the supply and deployment tools can now be leveraged to global capabilities. So the Team Europe now has become the backbone for global Europe. And the clear legal framework that was developed in the process. And looking at the second initiative, the Kovacs, that was launched in April 2020 by the Coalition for Epidemic Preparedness and Innovation, the Gavi Alliance, the WHO, and the UNICEF. It includes 192 countries and affects more than 7 billion people. So it's a global initiative, not a regional one as was the EU. It helped avert 2.7 million deaths across 92 lower-income countries. Most of the countries were in the global south. And here, there was also another innovative mechanism, financing mechanism, which was the Advanced Market Commitment, which was an innovative financial mechanism where doses were largely funded by donor governments that could help other countries that couldn't afford them financially. What were the lessons learned in terms of challenging for the COVAX initiative? When you have all this broad, like over 190 countries, international organizations coming together, coordinating in an ad hoc basis, where is stability there? That's a big problem. So most of the countries in the crisis situation, they donated funds rather than doses. So they kept the doses and the vaccines for themselves. The distribution and logistic networks with export bans, with the supply chains and difficulties and challenges that were critical elements. And although the EU didn't take directly vaccines from the COVAX alliance, unlike other high-income countries, nevertheless, they competed more or less for the limited supply of the same vaccines. And some countries, they acted independently just for policy of vaccine diplomacy by circumventing the COVAX. So there was no solidarity or joint work there. In terms of the opportunities or benefits that you can see from there, so we have now a mechanism of decentralized authority and responsibility that is working and has been experimented upon, is kind of becoming more structured, has become now the largest purchaser of COVID vaccines in the market. And the COVAX scheme has the ability to iterate, can be adjusted and become scalable to any type of similar emergency. So the groundwork has been done. The last 3 slides that I want to just compare the two initiatives. This is like if we look at across the different governance dimensions, we can see on the first column I have the EU joint partnership and then the COVAX on the second column. When we look at the pattern of interaction, we see that the EU joint partnership was more hierarchical, top-down, a tightly knit exercise. Political influence and legal work was of paramount importance, whereas the COVAX was more network-based, more loosely knit, and it started from operational collaboration, which later took up some bureaucratic and political form of cooperation as well. They differ in the range of actors involved, the geographic scale. One is more regional within the EU, the other is global, global south in particular. The type of membership, the EU member states plus associated countries. The other is more open and flexible. So the legal form, public law, in the case of very legalistic in the case of the EU, more the private law in the case of COVAX. And the organizational structure, decision-making, is more consensus-driven in the case of COVAX. There is no board in the COVAX. There is a meeting where the different partners come together and it's coordinated by 2 of the partners, and then the decisions are made by consensus. So in principle, the EU joint procurement, in terms of controlling risk, it is in the controlling mode. It's more of a center-out hierarchical approach. There's a political legal boundary work that is being done. So initially, all the work has been done at the legal and political level. Formal decision-making, fragmented formal rules, bureaucracy, hierarchical decision-making and authority. And it's well institutionalized because it happens within a well-structured exchange of policy and a forum of well-known partners that they work under the same rules. And finally, the COVAX, it's different, it's more dispersed. There is coordination by mutual adjustment and reciprocity, and it's lowly institutionalized, and it's based on linkages that they develop and negotiation and emergent association. And that was it. Thank you very much. And I think there's, yeah, I think it's
Oh yes, it's my slides. Hi. Before I start, who of you have seen the old town of Gdańsk? Hands up. Okay. Who of you has seen the Westerplatte? Hands up. Okay. The Poles don't matter. The foreigners. Who of you have seen the Westerplatte? Who of you have seen the Solidarity Center? Okay. So Gdańsk is one of the nicest places in Poland. Okay. And I don't expect you to come again, so I propose you take your presence here to the maximum. So, in addition to the old town that you may have seen, well, I am my second hobby is to organize trips, but I am from Warsaw, so I'm just giving you some hints. Okay, Westerplatte, which is like 3 kilometers this way, is the place where the Second World War started. So, in terms of the historical significance, it's quite an important place. The other place is the former area of the Gdańsk shipyard when the strikes in 1980 took place, the Solidarity movement started, which resulted in toppling of the communism. There is a museum there. And very importantly, one level down, and this is one that you don't have no excuse, there is the Museum of the Second World War. So if you're in the building, go one level down, there are the entry tickets, and the museum is super new. I mean, this building has been built maybe 3 or 4 years ago, and it's very nice, slightly depressing, but if you're in the building, at least take advantage of it. I guess Greg, as he is from Gdańsk, I think he should be more knowledgeable than I, but I took advantage and liberty of giving you some hints. So kindly, I hope you use your time to the maximum. Okay, coming to the COVID. It was very interesting to hear what you were working on, what was the focus of your deliberations and work, because we did something completely different. And our approach has been extremely hands-on, and our approach actually shifted and adjusted to the changing reality, because PCPM is the Polish NGO, but we operate the only emergency medical team in Poland, which is classified by the WHO. And actually that photo summarizes what we've been doing. I mean, we've been in the sharp end of the COVID response in numerous countries. Well, yeah, good. So I'm sometimes laughingly say that PCPM is like a wedding cake, with the base being the development aid programs, which tend to be multi-year. The thickest part of the pie are the humanitarian aid programs, and especially now after Russia's war against Ukraine, we have a lot of work. But then there is the cherry at top of the pie, being the emergency medical team, initially established to give us a rapid response capacity. It has grown much more than that. Currently, we are operating a quite sophisticated facility on the border of Poland, Ukraine, which is an integral part of the medical evacuation system from Ukraine to the European Union. Just to give you a bit of a background, what was our starting point, because we have had a number of deployments and work under the auspices of WHO in the previous years. Normally, the missions, normally the emergency medical teams are deployed for natural disasters. There is an earthquake, there is a cyclone, there is, some sort of a sudden onset natural disaster that overloads the healthcare system, and then at the request of the local Ministry of Health, under the auspices of the WHO, the emergency medical teams are deployed. And they are normally the type of the emergency medical team we field, which is a type 1, normally is about 20 staff that is deployed for 2, 3, 4 weeks at maximum. And then, the emergency is over, we go back home, get back to our regular work, and wait for another emergency to happen, which normally takes about once a year or even less. So this is like really ad hoc activity, but that modus operandi has completely the COVID pandemic has turned it completely upside down. One of the examples of like those classic emergency deployments is the deployment we had in early 2022 to Madagascar, which you can see from those graphs has been affected by 5 cyclones in a matter of 1 month. And we were deployed there under the auspices of the EU Civil Protection Mechanism, because we are also the part of that system. So here is the list of our recent deployments since 2015. And as you can see, the ones marked in yellow are for COVID. And those the frequency, not only the frequency, but also the duration of our missions has completely changed during the COVID. The Polish Emergency Medical Team, we are one of those who have been really working hard, and we've been really very active during the COVID. There is about 35 emergency medical teams currently classified by the WHO. The one which is the most active was the British, which had 25 missions. The second one was the Australians. I don't know how many Australians did, but something over 10 missions. We did 8. And then what I will come later, there are numerous governmental teams that were stranded in their country because the political pressure did not allow them to deploy. I mean, we did our best, but as you can see, some of those missions lasted for months. So our previous modus operandi of going there for 3-4 weeks and coming back home started to unravel. But even now, if you look at the bottom of the screen with the war in Ukraine, not only us, but also our emergency medical teams deployed in Ukraine. We are deployed there for months, especially actually since the war started. So the COVID was just harbinger of a certain change in that system of global emergency response, which is taking shape right now. We did two parts of the mission, two parts of deployments. One was the clinical care or intensive care unit support, where actually the Polish medics, but also teams from other countries provided additional staffing, additional expertise support for the intensive care units. And our first mission was to Brescia in Italy back around middle of March or 20th of March 2022. So right now, right in the beginning of the COVID, we also worked in the largest COVID temporary hospital in Africa, which had 800 beds, and it was in Addis Ababa. But quite unexpectedly to us, WHO out of a sudden wanted us to deploy to various countries such as the Central Asia, Kyrgyzstan, Tajikistan, or to Madagascar, and actually to train people how to properly provide medical care for the patients with COVID. And that put us in a bit of a weird situation because, you know, the doctors, a good doctor is not necessarily a good teacher, right? A good doctor doesn't mean that this person can actually transmit or share the knowledge they have. So, it just showed that, WHO was using any tools that had at their disposal, and one of those tools was one of the few tools available were the emergency medical teams. So, just giving you a few examples. This is the Brescia protocol for the IRDS, so acute respiratory distress syndrome, so the acute stage of COVID. And it was developed by the Italian doctors, and big hats off to them back already in March 2020, and this was the first take to actually make sense how the COVID progresses, what are the prognosis for the patients, what should be used. This was the time when the thrombosis, so the clogging of the veins in the body, but especially in the lungs, was identified as one of the main killers for the COVID, and so on, so on. So also those missions facilitated, not only in our case, but also in the case of other countries, that sharing of experience and knowledge between the countries, which was extremely important. The other example is this. This is as you can see from the writing on the bottom left, I don't know if you see those small characters. This is Ethiopia. This is the biggest exhibition hall in Addis Ababa, which was turned by the Chinese into a temporary hospital. It's on the way from Addis Ababa airport. It's called the Millennium Hall. It had 800 beds with a few ICU units. And this was actually very well thought, very well designed. The Chinese set it up for the Ethiopians. And when we deployed there back in September 2020, none of us as the Polish medical staff ever dreamt in our worst nightmares that 2 months later we would have exactly the same in Warsaw. And funny enough, the kind of the nitty-gritty, the small details we have managed to learn in Ethiopia and other places helped us improve and better roll out the temporary hospitals we had in Poland. So that inter-country sharing of, international sharing of knowledge turned out to be, one of the positive things. So I just wanted to, show you how the international emergency response system was overburdened by COVID. Here you can see the number of requests for international assistance of the emergency medical teams issued by the WHO in the years preceding COVID and during COVID. So as you can see, there were 2-3 calls of assistance per year in the preceding years. Something about natural disaster, something about the man-made. There was on and off some individualized outbreaks, such as the, I think there was a cholera in Bangladesh, there was the Ebola in DRC, and there was in Samoa, there was measles. I mean, come on, measles, right? But Samoa really struggled with this. I mean, come on, that's easy, right? It's measles, Samoa, off we go, right? I mean, not us, the Norwegians went. But all of a sudden, in 2020, that number of requests spiked to 13, out of this, and furthermore, in 2021, in Spike 221, everybody was screaming for assistance, and there was hardly anybody who was able to deploy, and from the emergency medical teams. And in a matter of fact, most of those requests remained unanswered. There was nobody able to deploy. The British, the UK Med, that also partnered with us in some of the deliverables under the HERoS, they have done 25 missions, which is like the biggest number of missions in the world for the COVID response. We did our humble part as well. So another aspect, and this is also in the deliverables of from our work package that we were showing, is that there is actually a lot of lessons learned how to improve the works of the emergency medical teams that we have drawn from COVID, but also to much extent due to HERoS, because it allowed us and it also forced us to think back and to analyze what was wrong, what was right in our response. So for instance, so this curvature is the number of cases of COVID in Poland, and as you can see, it overlaps, or the lulls in the COVID number of COVID cases allowed the Polish medical team to be deployed. But when you had a spike, the Polish doctors were stuck at home. I mean, everybody had to stay home and everybody had to work in the temporary hospitals. And this was pretty much the same what happened all over Europe. So, so one of the recommendations that we have drawn from it is that we had to diversify our pool of medical staff so that, okay, the Polish emergency medical team would not only have the Polish doctors anymore, because if we have an emergency in Poland, it has shown that we are unable to deploy and now we are unable to assist other countries. So there are a few main challenges and a few lessons learned. I will allow you to read through it, but let me highlight maybe 2 or 3 the most important. Is that first and foremost, the severe lack of staffing. There was such a demand on the global healthcare system that an ability to assist other countries was severely constrained. Secondly, the less developed countries in Central Asia or Africa, they expected from those arriving teams really miracles. They expected us to stay months, like really 3 to 6 months. They expected us to bring even the oxygen generating plants. I don't know, I mean, this is the plant that converts oxygen into the piped oxygen that you normally get to the ICUs. The value of such oxygen generating plant is at least $300,000 to $500,000 per unit, right? I mean, those countries expected us to bring those things on board. I mean, some really crazy expectations, while we were just a bunch of doctors and support staff just willing to work and share and share experience, right? What was for me the most lame thing of the whole response is the lack of funding. I mean, in second half of 2020, there were so many missions that could have been undertaken, but nobody thought how to finance it. And WHO, even they were awash with money, hands off. Right? We have the money committed somewhere else. Why don't you find your own money to do the missions? I mean, come on. We had the biggest health emergency in living memory, yet funding of the mission became a constraining factor. But the lessons learned, as in addition to I mentioned of the diversifying the medical teams, was really to manage the expectations and. On both sides, but especially on the challenges, we were very much taken aback by the fact that many ministries of health, very often due to their own political considerations, you have a team of Polish or British or any other doctors arriving in the country, and we were not even given the license to practice. We were not even able to touch the patient, even though those doctors were stepping out from the bedsides in their home country to assist, I don't know, Uganda or Tajikistan, right? I mean, this was infuriating. Yeah, and then again, WHO didn't live up to, this was the very least they should get us. They didn't. So, a lot of mixed lessons, but I'm very grateful to HERoS for allowing us to participate and also take it down, because to be fair with you, the whole global emergency health emergency system transitioned from COVID right into the Ukraine war emergency, and much of that and much of those lessons would have gone to waste. I mean, I'm not aware of any lessons learned exercise other than this one that has been produced. I mean, we have been to the WHO conference in Armenia in October last year, and we were presenting the paper developed under COVID, under the HERoS about the COVID response of the emergency medical teams. There was nobody else talking about this. So as if this whole wealth of knowledge, throw it out of the window and let's move on, right? I mean, so I'm really grateful for Kees and the whole team for allowing us to focus on that. And I'm very proud of one more thing. I am a doctor of economy. But we now have an article in the medical journal, so we managed to do it. We managed to pull it off. But effectively, what was developed under COVID was published by the Cambridge University Press. So I hope that at least on the scholastic side, we tick the nice box. So thank you very much, and we'll be happy to take any questions should they at one stage arise. Thanks a lot.
Hello, please. Vabbè, faccio così. Niente, non mi aiuta. Okay. Yes, that's okay. Oof. Hello, everyone. I'm Agnese Rollo from Italian Red Cross. I work in the department development, health and social care activities. Before telling you the case study about Municipio Solidale, I'd like to give you just a few information about Italian Red Cross. We are plenty of this beautiful brochure, so please, when we finish, take brochure and all the like bracelets, pens, all the gadgets that Federica and I brought here for you. So we won't bring that back, only for you. And they are for free. Good news, okay? So really, I will go quickly because we are a bit late. Just a few information. Italian Red Cross is the most important voluntary association in Italy. And about the network, just a few numbers. We have 160,000 volunteers and almost 700 branches. 87 national societies supported during the year, and more than 160 partners and more than 55 corporate and foundation donors. In the brochure, you can find all the national programs and operation about health and social health programs, and everything is concerning humanitarian diplomacy, migration operation, emergency activity on the national territory. So you can have all this information, and specifically, you can have information about the COVID 2020 during the period, the crisis, about the service name, the time of kindness. So enjoy yourself with everything. I'm gonna give you later. Okay, so Kees introduce you just a little bit the case, which is, the name is Municipio Solidale and the Social Network in the years of the health emergency. So, yes, no, no. Yes? Okay. it's an example of concrete participatory crisis governance practices at the local level, in particular between the 8th municipality of Rome as 15th municipality. This is one of the biggest municipality of Rome, and a local network of volunteers named Casetta Rossa. No, sorry. Okay, just a short story so we can understand better the case. The then Prime Minister of Italy, Giuseppe Conte, in the press conference of 9th March 2020, closed the entire country until the 4th of May 2020. So which were the first action of the government to respond to the COVID-19 crisis? First, increase the resources of the Protezione Civile, civil protection, appoint an extraordinary commissioner, Domenico Arcuri, responsible for the implementation and coordination of all the necessary measures for the containment of the virus, create a task force of about 300 doctors. They participated all on voluntary basis, and close all non-essential or strategic production activities, so only supermarkets, pharmacy, and some essential services remain open. How did the Italians react? In the most critical moments of the crisis, you know that we started at the end of February. We already know that something really big was going on, was happening. So solidarity initiatives started to multiply. Donation to hospitals and research institutes, but also national and local association, charities, civil protection, and the Red Cross. They were all committed to assisting the most vulnerable people. So now we enter in the story. After a few weeks from the issue of the decree, the Prime Minister, the 8th municipality launched a service platform named Municipio Solidale for help and support for citizens to better deal with health emergency. In the meantime, in the same district, Casetta Rossa self-managed social and cultural center, established in 2002, decided to do something to stay within the pandemic. So they normally serve meals. They stopped for the degree, but then they restarted again. They continue to prepare and deliver hot meals for refugees and all those who need them. The idea was launched through a Facebook post and immediately became viral. There was a desire to participate, of course, in full compliance with the rules. At the same time, the administration of the 8th municipality started Municipio Solidale and involved all the local realities, including Casetta Rossa. So it was born a dance network made up of intermittent social bodies, and an interesting mechanism was created to bridge the institution and the widespread social cooperation. The Municipio Solidale, at the very beginning, made home deliveries of food and medicine, immediately activating a phone number. But when the requests of the vulnerable increased together with the association, which wanted to be part of the network, then the 8th municipality started to formulate formalized procedure and decided to authorize the volunteers. This was a really big decision. Only a few municipalities decided to do this because there was not a central guide from the Roma Comune. So they authorized the volunteer, and they received a formal letter to show to the police during the various road checks. They were real guidelines, what before exposed Kees. So to be followed by the volunteers to comply with the rules and regulation of the lockdown. They were translated into several languages and not only transmitted on social network, but the people were allowed, went in the buildings and fixed the poster. So especially for the other people that they don't use Facebook and they don't use social, was important to, go to the supermarket once a week and read what the municipality give you as instruction. In April 2020, so after a month, worries grew more and more due to the spread of the virus in Europe and the rest of the world. And Municipio Solidale started by offering a psychological support service. It was an important support, especially for those people who did not take their salary because of their irregular job. So volunteers of association and phone operators of platform started to have a really hard time because of the increasing complex question, and they were not able to answer to the different needs. The number of people in difficulty grew exponentially, and the users who needed help were very heterogeneous. So children with family, elder couples, and many young people. But the network started to promote another service called suspended shopping. I know that it spread, in Europe, it's very common. Spesa sospesa. In Italy, I was born in Naples, where you have in Naples everything. You have coffee, sospeso, so everybody go to the bar and take a coffee or something like this. Book, libro sospeso. So the donation was made by customers who left packaged product. Local market were involved too. In a few days, more than 20 businesses were part of the project. There were problems, of course, to collect fresh food because the municipality was not ready. They normally don't have a warehouse to store stuff. So they were not ready for this kind of crisis. The volunteers so the delivery had to be done during the same day. The volunteers got specific training to use personal protective equipment, in particular, of course, when the face mask became mandatory. Municipio Solidale gave support to 2,500 people, thanks to the work of 350 volunteers. It kept on helping vulnerable people, even when the government gave to people the shopping voucher, but they arrived really late because of bureaucratic delays, of course, and they were destinated only to a small part of the people in difficulty. But they didn't offer only food and medicine. Municipio Solidale also thought of the need of the youngest, and in April was born Municipio Solidale Younger, with the aim of guaranteed distance learning for all children. Through the support of 7 national and international companies, there were collected tablets, smartphone, and SIM card, and in coordination with school, they were distributed to children who had no chance to follow lessons by remote because they live in poor living condition, like they live in caravan or home without the ability to access the net. In addition, the social network promotes cultural events like Libri da Sporto. So you could go to a bookshop. That was from May, almost. So you could go to a bookstore and receive a book for free, just because as a donation or somewhere else. So there was a menu of the book, or the book would be bring directly at home and packaged in the food package. and they promote the cultural events like Radio Anticorpi, which was not only an active resistance during a difficult moment for everyone, but also provide information like the scientific explanation on how the virus spread. So here I'm explaining the different phases because Municipio Solidale stopped in July 2020, but reopened in December 2020 when the contagion curve began to rise rapidly, and didn't stop till 2020 because it helped people from Ukraine. About the second phase, they help a total of 1,000 people. And in the third phase, they help 500 families. But the problem were serious, like they help to face other critical problems like housing situation, the lack of work, psychological and relational difficulties, and citizenship rights. So, as I told you, Ukraine. After a few months, so it was April 2022, it was born Municipio Solidale L'Ucraina, which took care immediately of about 50 mothers and children hosted in a hotel, part of a network of hospitality hotels managed by the regional civil protection. The 8 municipalities, again together with the association, supported them by providing food, clothing, and engaging them in territorial activities and school, sports. So, as my professor Kees taught me, which are the main lessons learned and recommendations? Okay, of course, it's a small example, even if the 8 municipality is 140,000 people. I mean, it's not so small. We thought, when I say we, it's me and Kees, that Municipio Solidale could be a model. And the case shows that local initiatives will last and grow into stable charity mechanisms and have the potential to become part of a whole of society governance mechanisms. The lessons learned are different and several and very interesting, like support local initiatives by establishing a central coordination body within the various municipality or district that can develop a clear guidelines. In Rome, in 2020, only 3 municipalities adopt this system. The other 12, they didn't have any system and they had lots of problems. Other lesson, expand the capacity of emergency professionals, so to work with local volunteers in order to increase the effectiveness and efficiency of all intervention. Then create municipal spaces, as I told you before, there were no warehouse to house material and to coordinate. Of rules and action. Support crowdfunding tools as a possible fundraising channel to deal with the crisis. If you take the brochure, you will see that Italian Red Cross did a lot during the period of the crisis. And if you go at the end, you can read clearly how many donations, many funds they received, and how support crowdfunding tools is important. So thank you. Oh, that's just leaving. Thank you very much. So now there is coffee break, but if you have any question, especially to the others.
Okay, I hope everyone had a nice chat over break. And we are ready to go. I would like to thank organizers for giving me a bit of time on the stage and for organizing this event. I will try to be brief, as I expect that everyone can't wait to see the movie. At least I am one of them. I will present to you today a little bit of our project Resistire. Resistire stands for responding to outbreaks through co-creative and sustainable equality strategies. And what the aim is to understand how the policies employed during the pandemic impacted the behavioral, social, and economic inequalities from gender perspective. Then to co-create the solutions based on the insights that we gain, and then empower policymakers and other relevant stakeholders. The scope was pretty much all of Europe, so all EU member states, plus Iceland, UK, Serbia, and Turkey. And how we did that, because we had only limited number of partners in consortium, those partners acted as national researchers for their countries, which covered 9 countries, and we employed 22 national level researchers from our network that helped us map, analyze, and gain insights to the subject. Those experts were mostly from gender studies and intersectionality backgrounds. The framework, of course, COVID-19 was the main subject, and we investigated under 9 gender inequality domains under EC Gender Equality Strategy and Beijing Platform for Action, which are gender-based violence, work and labor market, economy, gender pay and pension gap, gender care gap, decision-making in politics, environmental justice, and human and fundamental rights. And we considered various inequality grounds, such as gender, sex, sexuality, ethnicity, age, etc. And how we did that? We did that in steps. 4 steps: insight, creativity, solutions, and outcomes. And each step led to another, and one cycle like that was repeated 3 times, where the insights from one cycle went into another cycle and another. We started in 2021, and we are currently here, so at the end of our project. So what was exactly done? So in the first step, insight. We did policy mapping and initiatives. First, we focused on COVID-19 related policies and initiatives. We, of course, couldn't map all of them, so we asked national researchers to map more or less 10 per country. We mapped 298 policies and 277 social initiatives and analyzed them. In the subsequent cycle, we focused on the national recovery and resilience plans. So each member state needed to come up with one, so we wanted to see how well gender and gender inequalities were considered there. And in the last cycle, we focused on the better stories, so the inspiring practices that were identified in the first step. And mapped 128 of them and had 31 interviews with the people responsible for creating those initiatives. In the quantitative indicators, we focus on the rapid assessment service. So during the pandemic, there was a lot of those fast-paced surveys to see the impact on various subjects like work, health. So we mapped and analyzed 291 of them. then took a deeper look at the RAS and focused on those that considered age, sexuality, gender identity, nationality, and relationship status. And from them, it was 62 RAS from this step that considered that, plus 25 new were identified and as well analyzed. And in the last step, we wanted to focus on the surveys that took place more than once over the pandemic. So let's say longitudinal study over time. And this analysis was supported by additional analysis of the European level data, mostly from Eurostat, collaboration with selected rapid assessment servers to create new questions, get deeper analysis, create handbooks, and employment of our own survey, online survey mobile app. And finally, qualitative, it was focused on 3 ways of doing things. First, workshops with inequality experts. In each cycle, there were 3 workshops, and in the last one, we focused mostly on the civil society organizations that were mapped in the policy step. Interviews with national level experts, and individual experience with mostly women living and creating narrative analysis. So as you can see, we had quite substantial body of data to analyze. All of those insights in each cycle were consolidated and went into the co-creation. And based on the issues identified there, we created themes for co-creative workshops, open studios, very intensive, involving various types of stakeholders. So internal partners plus first responders, experts, creative minds, just to have the diversity of thought to create innovative solutions. You can here see that each cycle had 4 of such workshops, and in each we got more or less 6 to 7 action ideas. Action ideas could be some kind of pilot, social innovation, recommendation, research question. Those outcomes later on were put into the another workshops, more work, and developed into concrete solutions. And those solutions were, as I said, concrete actions, recommendations, and questions to be answered, which go to our outputs. Here, advocacy, our recommendations. Each cycle had more or less 6, 7, 8 recommendations for the policymakers that came from both co-creation, but as well as insights, because of course we cannot cover all the insights that we gathered with just 4 workshops. And we launched pilot projects, pilot actions with NGOs and CSOs that covered various topics. We have 9 of them. 4 of them already ended from the first cycle, and other ones will end more or less now. They covered various topics such as, for example, toolbox for schools and how to engage parents. In this particular case, the organization was focused on the Roma mothers in the rural Hungary. Another one, creating green spaces as ecosystems of care, how to make the green spaces more socially accessible, how people can meet. And we learned from the analysis that access to such spaces were crucial, especially for the mental health and for people to stay sane during the pandemic and lockdowns. Here's one of our findings and recommendations for the National Recovery and Resilience Plans. What we found is that, nonetheless, that we had a couple decades of gender mainstreaming. It was still not translated into concrete solutions during the takeout and design of the national plans. The gender impact assessment were still not taken seriously in most cases. despite the surge of gender-based violence, as everyone most likely know, that there was a lot of domestic violence, a lot of situations, the national plans ignored the issues in most cases. And most of them excluded women's perspective during the design process. And a lot of measures were aimed at women, and girls are often grounded in gender stereotypes. But nonetheless, we found some better stories. So for example, in Spain, the gender equality and reinforcement of social and territorial cohesion represented the central role of the national plan. In Northern Ireland, Women's Policy Group prepared COVID-19 feminist recovery plan. And Italians had a gender impact assessment that was conducted to understand the impact of those measures on women's employment. A bit of self-promotion. All of our results, or the upcoming ones, are available in our Zenodo repository. There are all the fact sheets, all the reports, data sets. Our server is still running. We want to have the last push to get more data before the end of the project, so I invite you to share your experience from the COVID times and its impact, how it impacted your life. The survey is anonymous, so you don't need to worry, of course. And in 1 month, we will have our final conference, so I encourage you to register and follow us. You can either join us in Brussels or follow us online. We're really streaming the conference, and more results, more deeper insight into those results will be presented there, as final full conference is needed to present the project, not 10-minute speech. So thank you for your attention, and please follow us on socials. Of course, if any questions, don't hesitate, or you can always catch me somewhere around.
Hello from me too. Adam, I'm saving all my questions after I read through the results and come to your event. I have already registered. So I'm really happy to be here right after Resistire, because their topic is closer to my personal research, but today I'm here for RESPOND, not my personal research. So, as you know, I am here to represent RESPOND and delve more into how the pandemic has affected mental health. The other presentations have already primed you very well into thinking that, yeah, mental health was quite heavily impacted during the pandemic. Let's hope that we can get my slides. Yeah, so. RESPOND stands for Preparedness of Health Systems to Reduce Mental Health and Psychosocial Concerns Resulting from the COVID-19 Pandemic. The project still has 1 year to go, so I can only share some preliminary results and main highlights, and next year we will have a lot more. So, we consist of 14 partners from several European countries, Australia and the UK. And yeah, so our objectives are to identify which groups are vulnerable, at risk, which means susceptible to experiencing psychological distress related to the pandemic, and also resilience factors to that kind of distress, and to examine the impact the pandemic has had on health service use, especially mental health service, and how this has been associated with socioeconomic factors, so that we can address such mental health consequences of potential future crises more effectively. Also, we aim to assess the policies and the measures that have been taken to protect mental health and well-being of those high-risk, vulnerable groups. And thus to make sure that in future crises, the policies that are implemented are more behaviorally consistent. And very importantly, we aim to implement and evaluate some psychosocial care programs developed by the WHO in a form of stepped care. I will explain more about that later on, and also you can find the complete description in our materials at the exhibition area. And of course, after we evaluate these programs, we want to provide evidence-based guidance to scale them up, so to make them suitable for implementation in other contexts of different sizes, probably, to support mental health and socioeconomic. Yeah. So here in this picture, you can see the structure of the project, also geographically, in short. Yeah, we have data from before the pandemic as well, during the pandemic at different stages, and now from these months that some people consider after the pandemic, including me. So we are structured in 7 work packages, the most important of which content-wise are 2, 3, 4, and 5. So work package 2 focuses mostly on combining and analyzing some cohort studies from different European countries. Most of them, fortunately, have data from before the pandemic as well, to identify the factors that are related with this ecological distress that I'm talking about, resilience, as well as adherence to lockdown measures. And as I said, we are combining all these studies, but this is still ongoing, so we don't have results from that yet. However, these individual studies already have results, and at least for the short-term impact of the pandemic, we can tell you that the vulnerable groups that emerged are women, young people, healthcare workers, people in a precarious employment status, meaning mostly unemployed or with seasonal work, and people who were quite lonely, and those with pre-existing physical and mental health conditions. These are even bolder among migrants and refugees because they have limited access to healthcare. And factors that have been associated with distress are loneliness and decreased activity, which you can very easily assume were exacerbated during the pandemic. And apart from this, we also delved more into these prevalence issues of distress by conducting an umbrella review, which was in collaboration with the WHO. An umbrella review is a systematic review of systematic reviews. And for this question, because it had more questions, I will come back to that, of prevalence, we compiled systematic reviews that included epidemiological studies. We hoped for more longitudinal ones, but most were cross-sectional. And we found that depression and anxiety were indeed increased during the pandemic, even though not that much. The increase was small but significant. And depression was elevated for longer than anxiety. And there were fluctuations across time for both depression and anxiety. And that was in relation to lockdown stringency and the number of COVID deaths. But we have to say that the groups that emerged as vulnerable, because there were very important differences across demographic subgroups, were again those I said before: women, young people, people with pre-existing physical and mental health conditions, all of that. But we really lack longitudinal evidence. We need a lot more, because this really mixes the evidence. And work package 2 is also pending some interesting results from registry-based studies from the registries of Sweden, Lombardy, and Catalonia. You know very well that these areas had very different approaches to the pandemic, and we want to see whether there were different patterns of service use, both primary care and specialized care, and also the patterns in suicide, and how this has been associated with, again, social and economic variables. And speaking of healthcare systems, we come to our third work package, which focuses mostly on policy, and it employs mixed methods to find out what policies have been implemented, whether mental health care was taken into account, So they had one qualitative study with interviews with experts. They were mostly from Belgium and the UK, but I think they're still conducting some interviews. And what they found was that initially there was so much uncertainty and lack of knowledge for this situation that mental health could not be a priority. But later on, it came into the table, especially as an excuse to reignite the economy. But the evidence is still quite mixed, so we can't really determine the extent. But something that is important is that there was some miscommunication at the different levels of governance, so regional and federal, and things seem to be quite shady. And they also had this quantitative study, which is a survey with a discrete choice experiment, meaning they had 80 policymakers from Belgium and approximately 2,000 people from the general population from Belgium, the Netherlands, France, and the UK that had these scenarios of a pandemic, and they had to choose between two options, which were closing down everything, but and having lower mental health, but reducing cases. You understand that? And what they found in this is that policymakers were taking the number of hospitalizations and mental health into account when making decisions, but the general population only took how much their mobility was restricted when making decisions. So we can see a discrepancy already, and there are still more data to come from that. And speaking of healthcare, we have also another question in that umbrella review I mentioned before about the access to healthcare. For this, we had 38 systematic reviews, unfortunately of moderate to poor quality, and we synthesized them in a qualitative narrative nature. And we used a certain implementation framework. I don't remember the name now, but you can read the paper. And we found that outpatient mental health care, face-to-face at least, was indeed disrupted, as you would expect, but it switched to virtual teleconferencing, which went very well and was flexible and ensured continuity of care, which was a key matter. However, this was feasible only in contexts where there was sufficient technological literacy and support. So it is important in such cases to have support from the organizations in technical matters and to train the staff in regard with the technical aspects. And speaking of this healthcare and interventions, we come to our 4th and 5 work package. Yeah. No. There we test the interventions developed by the WHO in this step care format. Step care means first they receive some low intensity intervention, and if this doesn't work, we give them another that is more intensive. Doesn't work means they still score high above the cutoff in a distress scale. Depression and anxiety, basically. And we have 5 target populations. One is healthcare workers in Spain, Barcelona and Madrid. The other is nursing home personnel in Belgium. And in the work package 5, we have asylum seekers and migrants in Italy, Polish labor migrants in the Netherlands, and people in accommodation centers in France. And in all these sites, except for Belgium, we compare this program to usual care, so what they would get if this was not in place. In Belgium, it's just an implementation study, no comparator. And these interventions are, first is doing what matters in times of stress. This began off as a book based on acceptance and commitment therapy, and it turned into an app, which is a form of self-help with some guidance from peer helpers. And the other is Problem Management Plus, which is a form of condensed psychotherapy in 5 sessions with the main psychological strategies that have been found to work in many trials. And it's again delivered by peer providers, but in our study it is remote, online, to fit the pandemic context. You can find a lot more on that in our materials. And also, we adapted the original versions of these interventions as they were developed by the WHO in order to make sure that we meet the needs of our populations. For that purpose, we conducted qualitative studies with interviews and discussions. And then we adapted a bit the manuals, and then we could test them. Unfortunately, we don't have results yet from the 5th work package, so Italy, France, and the Netherlands. The studies are ongoing. I can only tell you that we already see that they are quite distressed, more than we expected. And from Spain, we found that first, in their qualitative study, that this has to be approached at a multi-level, so from the intra-individual to the systemic. It is not enough to just sit in one. And the themes that emerged as the most important for the healthcare workers were fear of infection, guilt, psychological distress, interpersonal conflicts at work, lack of equipment, and they tried to employ some strategies to deal with them. And it was effective for the personal and interpersonal matters, but then their needs that touch upon the systemic level have not been met. And moving on to our trial of the psychotherapy program, it is effective, the effect is moderate, but it is very robust, meaning in several analyses we found the same things. It reduces depression and anxiety after both of the interventions. It doesn't reduce PTSD symptoms, though. And this fact that it is very robust means that it is suitable for scaling up, so to be implemented largely in other contexts. Also, after each one of these psychotherapy trials, we are conducting another qualitative study to evaluate the process of the implementation so that we can give very well-informed evidence to the policymakers to make decisions that meet the needs of the population as much as possible, or at least we hope so. And I can tell you for now that our main take-home messages are that we need to have large, representative, and most importantly, longitudinal population surveys to identify early which groups are vulnerable in each crisis, not just pandemics, because this might be different in every crisis. And then, after we can identify them, we can provide them with targeted support. First, financial, which was consistently associated with improved mental health. But this has to be proportionate, because not everyone's needs are the same. So to determine the extent of the financial support, we do need the data. And also to know to whom to provide psychosocial support as well. That's why we need this data. And of course, the mental health needs at the workplace need to be a priority. And all of that needs to be with having continued recovery in mind, not just the short-term effects, because as we see, new crises occur too quickly, such as the war in Ukraine after the pandemic. And this might continue with climate change in mind. So the plan for continued recovery is important, and not just these short-term immediate impacts that, unfortunately, policymakers are often engaged with. And we will have an event in Brussels, along with Resistere and other projects from the same call, in September, on the 7th, I think. And if you follow us on social media, you can find out more about that in the coming days. We are about to have the invitation ready. thank you very much for your attention. And I'm happy to answer questions if there are any. Okay, thank you.
Last but not least, and I really hope you are still awake. Thank you so much, Christina, for your beautiful presentation. And it's actually nice that I'm after you because I'm going to elaborate a little bit on some of the topics you mentioned. Because I'm going to talk about the COVID-19 crisis response in Dutch secondary schools. As most of you know, I'm Lianne Cremers. I didn't do this research alone. I did this, of course, with Cato Janssen. And Yiannis and Kees also played a key role in the whole process, of course. And you may wonder, like, why secondary schools? And it came up to us, actually, while we were looking at the pandemic. All the focus was on the physical vulnerability of those people who ended up in the hospitals. And we were interested especially in this vulnerability paradox, because youth are much more limited maybe to the physical consequences of the virus, but they are believed to carry the biggest socio-emotional burden of the pandemic. So that explains a little bit why we actually wanted to focus on this particular group. It's actually our project in the Netherlands is part of a larger project that has been conducted in the capitals of Finland, Ireland, and the Netherlands. We interviewed 90 people, and we used, as Kees already explained before, a whole of society approach. So we wanted to look at the authorities, outbreak management teams, ministries, but also the organizations, the student unions, teacher unions, municipalities, public health services, and of course the local level, which are of course the schools, principals, teachers, and students. And what I'm going to focus on now is actually on this local level, the schools. Because in the Netherlands, we did a little bit of an extra project, which is called participatory action research. And just to check if everyone is awake, who has teenager children or contact with teenagers in his daily lives? Can I see hands? So that's good to know. So maybe some of the things I'm going to tell you might ring some bells. And if not, maybe there are some new things to learn today. If there's enough space in your head today left after all the presentations, of course. First of all, what is participatory action research? It actually means that you co-create your research design together with your respondents. So instead of us going to the schools and saying, okay, we're researchers and we want to do research about COVID-19 crisis response in your schools, we were like, okay, this is actually a very broad topic still. What is important for you to research? What do you feel is very urgent to look at and investigate in depth? Another thing is that you jointly try to enhance this understanding. So you think about how am I going to collect the data together? How do I want to disseminate my research findings? So it's a joint project along the way. And the goal is to develop not only valuable scientific knowledge, but what you really want is action in practice. You want to give something back with your research. How can you help them with the crisis they are in and the results that they have been confronted with in this time? And what is key actually of this kind of research is that you use creative methods. So you don't have only academic output, but you also have creative output. And I will come to that a little bit later, because that was also a very nice brainstorm with the schools we engaged with. Oh, wrong side. There you go. So what we did, we had the students and staff of secondary schools, and they really functioned as co-researchers. So they had a prominent role in the research. And in the end, we had 3 secondary schools that collaborated with us. And what they said when we had our first discussions about what the urgency was about this topic was, oh, we want to know what the role of students was. How did they experience this whole crisis in schools? Or what did they feel they have a voice or role in all this? And that is actually touching upon a whole body of literature that Kees already mentioned as well, and is most often referred to as participatory governance. And the idea is that citizens or non-state stakeholders actually has influences on processes of decision-making that impact their lives. So they're actually going to get a voice, and they can, because of discussion between all these different stakeholders, you can get very new perspectives, you can get creative solutions, very unexpected sometimes. And we were curious whether this idea of collective ownership of students, whether they felt they had some ownership in this process, occurred in these schools. The creative research design that we came up with was art-based engagement ethnography and visual ethnography. That might not ring a bell straight away, but I'm gonna talk about that after this slide. And it resulted, to give already an idea, in an art exhibition, which some of you have seen last year in Amsterdam, because that's when we presented it to the on the HERoS Symposium, and an ethnographic film. To see if you pay attention. Okay, let's go the other way. So first of all, we actually involved students in an art-based engagement ethnography. And that meant that we organized art workshops with the students, and we asked them, can you portray how the COVID-19 pandemic has been for you? And can you explain what happened in the outside world and what happened to you? And what was your role in relation to what happened regarding the COVID-19 crisis? And that actually resulted in beautiful stretched canvas artworks of the students. And maybe you can imagine, because we conducted the data collection in the autumn of 2021, the hot phase was already over, but we were still in the middle of the crisis. But you can realize that there's some hindsight bias, like you have to recall what happened already from a year ago. And I can tell you that if you work with art, that's a beautiful way of getting back in this previous experiences and really put your emotions in there. And we use these as vignettes for in-depth interviews, and that led to beautiful and very emotional, touching stories of these young people and how they have experienced the crisis. And that was followed by the art exhibition, but also presentations of the students and a dialogue. And I get 0 points. And the other thing is visual ethnography. That needs maybe some explanation. I'm a visual anthropologist, and that literally means that I do observations and interviews, but I bring my camera into the field and I film this whole research process together with Cato, by the way. And it's a really beautiful way of not only collecting the data, because the camera can really work as a catalyst. I realized in many of my previous research projects, because respondents really feel that they are taken seriously. They're like, okay, you come here with the camera, so my voice is going to matter. This is my story, and it will go somewhere. There will be an audience, the film will be watched. So it gives the research some seriousness that actually make them much more involved. So it helped a lot. And we also organized vlog workshops for the students, so they could make video diaries. And in this way, they also had control, like how do I actually want that the research findings are portrayed? Because they were in charge of what was being filmed and where and in what way. And in the end, we combined all the artworks and the vlogs and also the filming during observation and interviews into one ethnographic film. And the beauty of ethnographic film is that you can show suddenly the complexity and the layeredness of an individual's experience, which is sometimes really hard to put in words, as you might imagine. And another important thing is the audience. Now, you sitting here after a long day and you've heard a lot of information, and it's very different if you hear dry facts, someone is telling you a story, or if you watch an ethnographic film, because it can trigger some empathetic understanding. You will maybe experience a more emotional response. And as a consequence, that can trigger some kind of engagement with the topic, and also maybe more motivation to change, to have societal impact, and to rethink, for example, policies. So I can tell you it triggered very interesting and stimulating dialogues after several film screenings. We had the premiere in October when the film was finalized, and we invited all secondary education stakeholders in the Netherlands, and we had a very, very good discussion afterwards and a panel discussion with all the people in the film. So we had 8 key respondents who were actually in the film. And we also had an impact campaign in Amsterdam, and 21 schools. They used the film together with an educational program to start a conversation among their students. What was the pandemic like for you? And what are the lingering effects? Because you can imagine now in the aftermath, we're all like, oh, the pandemic is done and over with, and we want to continue with our normal lives. But after seeing this film, students were really like, oh, actually, we've not really stood still, take a breath and look and reflect upon what happened to us and what that still does with us. So there were very interesting dialogues also among students that were initiated by this film. And it was also showed at the Youth Perspective Platform, which is the advisory organization for the Ministry of Education. And they also said one of the striking things they thought about the film was, oh, we keep focusing on those students who are very vulnerable. But after seeing your film, we realized that also the average student, about whom no one had a single worry pre-pandemic, were also struggling and had a really hard time during the pandemic and maybe need some aftercare or some reflection discussion or something actually. So they're taken care of. And the last one is that there's the week of the mental health for secondary education professionals, where we also screened the film. So you see that the film can actually be used for a very broad audience. So students, professionals, authorities, scientists, public health organizations, etc. The title of the film is We Thought It Would Be Fun. It's a title made up by the students themselves. And I think it's very illustrative for the period for many people, actually, not only the students. And we've also showed a draft version, so they were also kind of involved in the process of making the film. And they reported back that it is actually a very good presentation of how they have experienced the pandemic. What happened after the film, I can briefly summarize. So we had the impact campaign in the schools, and we had beautiful dialogues with the students that could recognize themselves in the film and also talk about lingering effects. But we also had, of course, the screening for the organization that advises the Ministry of Education, the Youth Perspective Platform. And we also showed it for secondary education professionals on the week of the mental health within this specific sector. So, and the film premiere itself, of course, for all these secondary stakeholders. And yesterday we presented, I forgot this actually, for the European Council of Disease Prevention and Control. And then all the authorities that are in charge in their European countries for school closures were there to have a discussion about, when to make this decision and what other measures can be put in place in schools to maybe prevent a school closure, since the impact on youth's well-being is quite big. Yeah. Any other questions? I think then this is the end of the day. Thank you so much that I could talk today and show the film, her film.